Hello, everybody. This is Michael Saltzman from Blue Sky Bio. Hope everybody's doing well, staying home, staying safe during these times. And we are appreciative that you're joining us. Everybody, this is Michael Saltzman. That you're joining us for this webinar and for the ongoing webinar sessions that have been going on and that continue to be going on. Please follow the webinar schedule of upcoming webinars. It is dynamic, it's changing. We're updating and adding to the schedule. So stay up to date, blueskyplan.com/webinars 2020, or on the Facebook groups, Blue Sky Bio user Facebook group, or the Viral Education Facebook group as well. As usual, we'll be sending the CE credits for this webinar presentation within 2 weeks' time via email. So look out in your inboxes and please be patient until they arrive. Webinars are recorded. This webinar is being recorded. You could view past webinar presentations on blueskyplan.com, on YouTube as well. You are able to get CE for recorded webinars by completing the 10-question multiple choice test. And just to clarify that if you're watching this webinar live as it's being presented, you do not need to complete the 10-question test. We will be sending you the CE credit straight away. If you have questions during the webinar presentation, please type them into the question and answer box, the QA box, not the chat box, but the question and answer box, so they could be addressed during the webinar presentation. We've introduced Dr. Robert Mikhli in the previous presentations. Practices in Brooklyn, New York, an expert in implantology, lectures extensively, and he also offers an in-office mentorship program for general dentists, providing hands-on instructions in implant surgery. So if you are interested in that, then please contact him directly. It's a great service, great option, so please keep that in mind. Today's webinar presentation is part 3 of the series that Dr. Mikhli has been presenting. The subject is implant startup. Robert?
Okay, welcome back, everybody who is returning from the past two lectures, and welcome to all new who are in attendance. This is our part 3. We're gonna review a little bit of the biology that we learned in the first one. We're gonna talk about the mechanics of implantology and how that works, and we're gonna get into planning and placing our implants. A lot to cover today. We planned this as a 1 hour. I know most lectures have been going way over. We've gotten some compliments and some complaints. So the answer is you still get your credit regardless. Obviously, you could log off whenever you'd like. But I'm going to try and really trim this lecture down to make it a little bit more time friendly. We'll probably run somewhat over, but try not to go way over as we have in the past. And what we can do is anyone who'd like more in depth of the slides that you're going to see me skimming through, I'm happy to set up a smaller group of whoever would like to join us for a more in-depth adventure. We'll set something up for next week. So you'll have my email address, contact me, and we'll set that up. Okay, just again, quick introduction myself. I went to Stony Brook. I did a GPR in New York Hospital, Queens Presbyterian, fellowship in oral maxillofacial surgery and implantology. So I got a really nice, well-rounded background in both prosthetics and surgery. My practice is limited to surgical implant procedures in Brooklyn, New York. We have an Implant Mobile Surgical Solutions sending doctors out to offices in the tri-state area, and occasionally some other further locations in the United States. We haven't yet done that internationally. We have the Implant Mentorship program, which is a teaching course, which again has been held in New York in the past. We had set one up for May in Israel, which would give people in Europe and Asia a easier location to come to. That was postponed due to our friend Mr. Corona, but we'll be rescheduling as soon as we have some idea when the world is going to get a handle on this. But you know, with every crisis comes different options and different opportunities. I've been trying to stress that to myself, and just thinking the world will be a little bit different when we all crawl out of this. It's just a matter of how are we going to react. Some things will be the same, but some things will be different. So we're going to have to be ready to adapt. And one of the things that I'm going to be offering is a virtual chairside coach. I've talked about it briefly in the last two lectures. I'm going to talk about it a little bit more in depth in the first couple of minutes here. So it's going to be offered worldwide. We can fabricate surgical guides together. So if you caught Corey Glenn's lecture, you'll already have a good background to it. If you've already been doing some guides yourself, you'll have an idea of how that works. If you have no background at all, we'll start from scratch and we'll work up your cases. We'll do the surgery together live via web conference, when we'll be able to speak directly, probably through a Bluetooth headset, which you'll be wearing, and you can show me exactly what you're doing. I'll see the x-rays in real time, and just the same way as you're coached through your early procedures in dental school will be the same kind of experience where you do a step, make sure you're doing everything right, and proceed, and you finish the case with confidence. So you can just take that next step in your surgical abilities that you were maybe too cautious to, because what if things don't go the way I expect them to? What if there's a complication that I'm not ready to handle? What am I going to do then? So I'm your backup, and we'll get you through whatever situation may arise. Again, submit the case materials. We'll talk about that in a moment, to my email address. And this is, again, if you're interested in going more in depth in this lecture, shoot me an email already now, jot that down. It's INplant, INplant, MSS@gmail.com. Shoot me an email, and I guess we'll do probably the same time, because if it works for everyone who's here, we'll do it again next week, and we'll just choose the date, and we'll make it happen. To send files, one of the options I use all the time is an option called Bio Big Box, offered by Blue Sky Bio. It's free up to several gigabyte, and if you're doing heavier amounts of files or want to keep files into the cloud, it's a few dollars to keep a paid subscription, but it's a HIPAA compliant file transfer, which means that everything's secure. Your patient's information is secure, much more secure than just sending via regular email. And it's also has a backup date of when it was sent, who was sent to, who downloaded it. So everything is kept neatly and very user-friendly. It's a drag and drop situation. You drag your files, drop them in, and they get sent to where they need to go. And there's also an option in Blue Sky Plan. With a click button, you can send that plan up to the cloud through Bio Big Box if you have a registration, and it can send it just very seamlessly. So again, it's a free service. Jump on it, and it's very, very helpful. So when we're talking about the case submission guidelines, I just want to go through that briefly. I started doing these guidelines myself in my office study for many years, and I find it to be very, very helpful just for reviewing my own cases, both for presentation of cases and just seeing what you may have missed during surgery. To see something in a photograph in really big makes things really easy to review and to see what you could have done a little better. I was told early on that the day you do your perfect surgery is the day to retire, because there's always something to improve on. So what we're first going to do is do an examination and understanding of our patient's expectations. It's really, really important that we are on the same page with our patients what the expectation is. We'll talk about that a little bit during the lecture, but understanding what they are, what is the patient interview, a chief complaint, and any secondary concerns. What are they looking to accomplish with this implant? You may think it's just replacing a tooth. They may think that their speech is going to improve, or some other issue that they're looking to improve on that they took for granted is going to happen, and may happen, may not, but you want to be clear with them, what is the expectation? So I just leave it as an open-ended question. Then I ask them, what can I do for you today? And I want them to tell me in their own words, what are they looking to accomplish? I know they're missing a tooth, that's why they're in my office, but I want to hear from them, what are they looking to accomplish? So we're going to go through a medical history, dental history, and I have forms that I use in my office I'm happy to share. A head and neck examination. I feel like this is sometimes overlooked in dentistry. We all learned it in dental school, but it's really very important and very helpful to be able to do, to screen patients for potentially life-threatening diseases, to be able to catch them in their early stages. A TMJ examination, and especially in our larger reconstructions, that's going to be critical to make sure we know exactly what's going on with the TMJ, not to cause a greater issue, or at least to document what they have existing. Because the last thing you want to do when you put a large restoration in someone's mouth and then they start complaining about a TMJ issue, you say, oh wait, did you have that before? That's not a question you want to be asking after the fact. You want to know what's going on and tell them we're going to be mindful of that while we place your new prosthesis. An occlusal exam, an oral cancer screening, a dental exam with perio charting, our radiographs, which is going to be a full mouth series, and a CT, if at all possible. CT is going to be really, really important as well. So if you don't have one in-house, I assume most places in the world have an imaging center near them that can send patients to. We're going to talk about some photography and some impressions of digital or analog. If you have an intraoral scanner, that's fantastic. If you don't worry, you can still accomplish what you need to with an analog impression, and we can talk about ways that we're going to digitize it. And then mounted casts, again, if it's digital, that's not necessary. If it's not digital, it'll be scanned. We want it to be scanned in occlusion. Our photography, if you notice, this is an ortho photography set, but we want to, for two reasons I do this. One, it's just an easy way for my assistant to be able to take these photographs and mount them, and everything's clean and the same for every patient. Second is, if you are doing ortho, this is an important series to have regardless, and if you're not yet doing ortho, it's a great option to already have the records for you to be able to get involved in ortho. And there's, again, Lab Pronto, there are services where we can work up cases with labs and Lab Pronto to get you a treatment plan with an orthodontist of what you're going to do for some simple aligners in your office. And it's really a great extra revenue with a skill set that does not require in the early stages much more than having someone else decide if this is an easy case or not. Sometimes things look easy and they become very difficult. You want an expert to see it and tell you, hey, this looks easy, but it could really turn sideways on you. Or this looks difficult, but really it's a very simple situation to fix this. So you can send it to Lab Pronto, find a lab that will help you maintain that and decide which way to go and go with it. So that's already right off the bat, your existing patients who are already in the office, you can offer very inexpensive, simple aligners as an extra means of revenue in your office, and just, again, expanding your services, which as you expand your services, you always expand your net of patients, because those patients will draw more patients, and again, it continues to run that way. So if you have not yet done ortho, Michael, are there ortho lectures on the docket?
Oh yeah, we will be having several different lectures. Dr. Baron Gruther is going to be getting involved, and we're
Great,
going to
fantastic.
be reading several.
Okay, so he's going to talk more in depth about it, but just to get in the habit of taking these simple photographs, it's really, you can train your assistants to do it. It'll require none of your time, none of your chair time. Just train your assistants to do it, and it's a very simple, easy way to add a service in your office. What we're also going to take is a couple extra shots. And anytime we're dealing with anterior teeth, or even sometimes posterior teeth get involved in this also, want to see their lips together with a face relaxed. Want to see their lips slightly apart. It's going to be important for the restorative of these teeth. We're going to want a relaxed social smile, which is just a casual smile. And then we're going to want a big exaggerated smile. I want to see how high does that lip get when they smile as high as wide as they can. And don't just ask them to smile wide, because if they're conscientious about their smile, and that's why they're there to see you, they're not going to smile really big. I'll either make a joke or something to make them get out of their discomfort and really let a smile go completely. And when they're just not in the mood, and sometimes you'll have patients who are like that, I just tell them, I don't even care that you smile. I want to just see how high your lips go up on your face, because we want to make sure, do we just have to fix a tooth, or do we also have to fix the soft tissue as well? And it can be a whole different ball game if the soft tissue shows. And you could do a perfectly placed implant into bone, and everything looks great, and then the patient is so excited, you put the new crown on, they smile really big, and you've got a large black gap above their crown, and nobody's happy about that. And it's become a failure just for a lack of planning in the beginning. So if you see that photograph early on, you can avoid many, many big headaches down the road. Good. Okay, so that's some of the background of just what information to take to be able to get cases running, so we can get your cases treatment plans together. Again, get as much as you can. The more, the better. But if there are certain things that are critical, like these X-rays, a CT scan, and some casts, but the other things are very, very helpful. But if you're missing one piece, don't feel like you can't submit the case. Still submit the case, and we can still go through it. I actually have a study club out in Brooklyn that we have a Facebook page called Case Collaborators. Sorry, I didn't type that in. Case Collaborators, you can search for it on Facebook, where we have doctors post cases both locally and from outside, where we discuss them live, and we do a Facebook Live group once a month. We've taken a break recently, but once a month we have a Facebook Live group discussing these cases with different specialists and different ways to approach complicated cases. Okay, so that's all on a side. If you're at the first lecture, we had the same graphic before. We talk about a goal, and we talk about ways to get there. So the goals generally are going to stay the same in terms of what we want to do for our patients. How we do that for them, how we get them back into a healthy and aesthetic smile is going to change sometimes. So we want to know the goals, those will stay there, but the puzzle pieces of how we cross that bridge are going to change as time goes on. And what we're trying to do here is give you more puzzle pieces to cross that bridge with. So we're going to envision the goal first and then find the best way to get there. So we talked about the goal of an atraumatic extraction, and that was to have an adequate volume of bone and tissue to serve as the foundation for the implant crown. And the goal of implant surgery is to provide support and anchorage for a prosthetic tooth in a functional and aesthetic manner. And I stress that because one without the other is not going to be enough anymore. Whereas just functional but highly unaesthetic, patients no longer accept that. And you know, last thing you want to do is have someone finish the procedure and the tooth isn't function, everything looks great to you, but aesthetics were just not part of what you were thinking about. And the soft tissue is a mess, and there's a huge defect, and food gets stuck there. The tooth looks fine where it is, but if you look at the bigger picture, it's not. So we're trying to look as big picture as possible here. And again, a patient, this is a picture of Demi Moore in the very early days of Twitter. And this was, I thought, very brave of her to post a picture of herself. She has an anterior, I guess it's number 9, I don't know if it's reversed, 8 or 9 implant, and it was, I guess, being cleaned. It was taken off, probably screw retained, taken off to clean, and she took a picture of herself and posted it. So people think that they're going to go from that to this. That's fine, but you have to look like Demi Moore first. And I have to stress that to our patients also. I'm just going to replace the tooth. You're still going to be you. It's going to be much better, be the best version of you, but you're not going to be Demi Moore when all said and done unless you look like that when you came in. So managing patients' expectations is also critically important. And why the photographs, pre-op photographs, are that much more important is when patients say, well, I don't like how this looks. It's not exactly perfect how I envisioned it. And then you could show a before and after picture, then like, oh, okay, that's a lot better than I looked when I walked in here. Thank you very, very much. And that's, again, you went from a angry patient to a very happy and appreciative patient just from a pre-op picture. So we talked about the goals involved. We talked about what we need to do to build up the foundation. So we talked about the atraumatic extraction to leave us with the best foundation possible. Today we're going to talk about the next step, which is going to be the platform, the implant placement that needs that foundation to be solid for this to work. Then superstructures, and then finally the final crown. But it all starts with the foundation, and then next step in building is the implant itself. So missing teeth. This is a picture of Ed Helms in The Hangover when he famously extracted his own tooth. Apparently the background to the story is he actually had a congenitally missing lateral, and they unscrewed his implant crown to shoot those scenes in the movie. So if you think it looks real, it really was. He was really missing a tooth. But if you look really close, right under his finger, you could see a soft tissue defect. Again, it's sunken in. He gets away with it because his smile, it's a broad smile, but it's not a very high smile unless he does that. And I tell my patients before we start, I will even say that. If I see a concavity there, I'll say, listen, we can do a soft tissue graft to try and mask that. But the only time someone's going to notice it is when you're in my chair and I lift up your lip, or if you do this at a party. So short of that, do you want to fix this? And we have the conversation, because if not, they had a low smile, you diagnosed it, you knew it, but then they finish, they smile, looks great, then they lift up their lip and they're like, what is this? And then you say, well, I didn't think it was necessary to do it. Like, well, that's nice that you didn't think it was necessary, but how am I going to live like this? And again, their expectation was way different than you were expecting. So it's all about having that conversation before rather than making an excuse afterwards. So options for missing teeth. So obviously, first option is to do nothing. That's always an option. And I always tell that to people. We could always do nothing. the tooth was taken out, we could do nothing. I'll talk about the cons with that, but that's always an option to the patient. A removable prosthetic, a partial denture is another option, or a full partial denture if they're missing all their teeth, or an implant. That's basically the 4 options they have on the ahead of them. So to do nothing, I always talk to them about pros and cons of doing nothing. Oftentimes they'll say, obviously I want to replace my tooth, but if they don't, it's a back tooth, do I really need it? Well, let's talk about the pros and the cons. So the pros are it's no further treatment necessary. We took out the tooth, we're done. But then they're going to look like this. If we have any Russian doctors in the group, that's not on purpose. He's wearing a Soviet flag on his shirt. But they can have the option of doing nothing. The cons are decreased function and greater stress on their other teeth. Again, missing 1 molar puts a lot more stress on many more teeth. And most commonly, people will start with missing their first molar. It's the most common tooth to miss, to lose. The most common first filling is going to be your mandibular first molar. The most common endo is going to be your mandibular first molar, and no surprise, your most common implant is going to be your mandibular first molar. So when that's gone and not replaced, it's going to put stress on other teeth, the adjacent teeth, and also their efficiency of chewing on that side is going to be decreased. So they will start to chew more on the other side. When that happens, down the road, a few years, they'll start to break down teeth on that side. Then they're forced to chew on their anterior teeth, and then they will start to break those down. So I just tell people, we're going to be doing implants for you at some point. I'd rather just do one than have to need a whole mouth of them 10 to 20 years from now. And that kind of gets people thinking about, like, yeah, I can't really just leave this. And one of the biggest things I get with people is when they ask me more so about bone grafting, they'll ask me, is my bone going to sink in? Am I going to look old? So it's really 2 questions they're asking, but I kind of answer them together. And I'll tell them, well, the bone will sink in. We talked about that research last time, but I'll talk about it from the standpoint of it may limit our options of implants for the future, or may require more grafting for the future. But once they heard about the potential of bone sinking in, they oftentimes will say, well, I don't want to look old, whatever it costs, I'm doing it. So I tell them it's more of your cheeks that's not really going to sink in just by missing a tooth, but as more teeth get lost, that's that appearance of that aged appearance. When teeth get lost and alveolus is lost, that starts the process towards that very aged appearance. And again, some shifting of teeth also can occur. So the teeth kind of work together as a unit. When you take one out, it's not just you're one less of the whole unit, but it's still, you're not just 1/32 less than you were with one. It's going to start the process of all those extra teeth having more stress. In RPD, pros and cons. So oftentimes I'll just show them what an RPD is, and we're already, on to the next conversation. It does replace the missing teeth. It's functional. It's certainly more economical if you're talking about multiple teeth. But the cons are you have greater stress in the clasped teeth. Those teeth will always get mobile over time, and they'll get lost, and you'll have to add to the RPD. And then eventually move into a full denture. It's very uncomfortable for most patients. It's removable, which is just not fun for patients to think about. They'll always say, I remember my grandmother used to have her teeth sitting in the cup. I never want to have that. That was frightening to me as a child. And what I stress to them is that the tissue-supported area is going to cause that underlying bone to resorb, and resorb very quickly. And we've all seen cases like this, where a patient has a couple of teeth that give good anchorage to that RPD for years, but now they have a fully resorbed mandible, if it's just in one spot or in multiple spots. And now we really are limited of what our options are to try and reconstruct teeth for this patient. It's a lot more involved trying to get this than had we grafted and put a single implant in years ago. Would have had a much, much easier time now. So I stress to my patients, you're really investing in yourself for the future, because the more we do now, the less we have to do in the future. For a fixed partial denture, kind of a bridge, those have a lot of pros. They replace the missing teeth. They're highly aesthetic, and they have a fast turnaround. When I talk to them about implant surgery, I'm taking your tooth out, doing a bone graft, I'm waiting for that to heal, placing the implant, waiting for that to heal, then we're going to place a tooth. It's about a 6-month process, start to finish. And I always tell them a little bit longer than I actually expect it to be, because again, I'd rather be a hero getting finished earlier than we thought than I have to explain afterwards that they're healing slower than we thought, and it's taking more time than they were expecting. So a bridge is an option for a lot of situations. But I will talk to them about the cons. The cons are we have to prep adjacent teeth. I remember a quote I heard from the late, great Carl Misch, where he said, if we cull teeth, the virgin teeth, before they're prepped, if we prep them just to be able to put a bridge to fill in the missing adjacent tooth, would that be tantamount to dental rape? He was obviously being a little bit facetious, but the idea is you're taking a virgin tooth and you're prepping it. We know as dentists that puts a clock on that tooth. We know that the odds of taking that tooth with them to the grave have greatly decreased by prepping it to put a crown in it. That crown will need to be replaced. That crown will eventually probably have an endo, and that tooth will probably at some point in life be removed as well. Much more susceptible to decay than implants are, for sure. All teeth are treated as a unit, which means that another tooth has that's great, but for the patient, again, it's a large expense that we can avoid if we're looking at implants. Then I talked about implants. What are the pros? So the pros are they replace the missing teeth. They can be highly aesthetic, no stress in the adjacent teeth, and that's one of the biggest advantages, in my opinion. The longevity of them, and we can have a long conversation about longevity of implants. I personally give a lifetime warranty in my office, assuming that they are taking proper care of them. And I judge that when they come in for also a mandatory annual exam. They'll see the general dentist for their regular hygiene, but they'll see me for an annual exam, and I will clean around that implant as well, or a set of implants, whatever they have. If they do that every year, what I learned is they really have very few problems. I place them well, they're maintained well. We really have very, very few problems. So the few people who will have an issue, I'm happy to give a warranty for. What I learned the hard way is early in my career, I'm looking to do the right thing by the patient. I think most of us are. And someone comes with a problem 3, 5 years, 7 years later, where they clearly have not been maintaining this well. Now it's going to need some significant grafting and things to fix this up. And just to nurse along an ailing implant, we really would have much rather see it very early on, talk to them about hygiene, and fix it before it becomes a big issue. So I started doing that to ensure that they come in. And now if they refuse to, and they just say, I don't have time for it, or I charge a $95 fee for including the x-rays and the cleaning around the area, just really to get them in the office to make sure that it's still doing well and not losing, my shirt doing it. So if they don't want to pay that, then we'll send them a certified letter with a contract that they had signed when we first started, saying we're giving them a lifetime warranty, provided that they're coming in. And now if they come in 3 years later and have 3 to 5 millimeters of bone loss because they haven't seen a toothbrush since they left the office, I can charge them for a graft and tell them about the ailing nature of their implant without a shred of guilt, because we're in a partnership together. We're there to help them in their dental health. But if they're not helping themselves, we're there to help them after the fact. But again, it's going to cost me time and materials. So I'm going to be able to charge for that as well. We're running a business. So for me, it just made the conversation so much easier. If you don't come in, totally fine. It's your prerogative. But just realize that your warranty, I can't guarantee the work in your mouth if you're not coming in to maintain it. And again, clear about it from the beginning so it doesn't become an issue later. The cons are time. That is the main con involved. Implants take time. People really just have to understand that going in. They understand that. No, we can't rush biology. It is what it is. If you can get an immediate implant in, great. But it's never worth saving 3 months of your life for decades of headache if something doesn't go right because the implant wasn't done properly as an immediate. It does require a minor surgical procedure. And cost, I leave it as a question mark because, again, a 3-unit bridge versus a single unit implant, you all have your own fees in your offices, but I think nowadays it's really pretty close, if not even slightly ahead with an implant. So And your built-in costs are pretty similar. So to me, I think that cost could be a wash at this point. I don't think the implants are a much larger expense than a crown 300 bridge would be. Good. And those are really important conversations to have with the patients. I'll have them more briefly. I have my office manager talk to them in depth when they're going through the treatment plan. And in my courses, I talk about that also, not just your end of it, but making sure your office is running all together. That not only did you go and take a course, but we're running education with your front desk and with your assistants to make sure that they know how to assist you. And also they know when you first treatment plan your first few implants and you leave the room, you know, a lot of doctors are surprised to find out how many times the patient will decide not on what you said, because they heard a little bit, but they weren't really listening to everything. And then you leave and they look at your assistant and say, should I do this? And if the assistant's like, I don't know, he's only done a couple of implants, they're not doing it. But if the assistant's on board and they feel like they're participating in this also, then they're going to say, absolutely, we're confident and excited to do this for you. And your front desk to be able to close cases and make sure that things are moving along. It's all part of the process of making sure implants are integrated into your practice. Okay, quickly, evolution of dental implants. Implantology is the second oldest dental procedure. AGD status for a show of hands what the first one is, but the first one is a tooth extraction. Approximately 2000 BC, we have skeletons of Chinese that had used bamboo shoots to kind of hammer into the area. Egyptians were using precious pins that we found on mummies to be able to create a new tooth. The Incas were using seashells. I like this seashell because it kind of looks like an implant, but I don't think it was a shell like this. It was more a shell like this, where they would chisel out this little, what would that be? That would be a lateral incisor, ancestral, looks like, and they would hammer it into place. And we know that this was successful because the patient didn't die of an abscess. So this actually was a successful implant. I'm sure many of them did die of abscesses, but this was a concept that they understood. We want to replace this tooth. Let's get something into that spot to replace it. We'll talk about a little bit about the evolution of implants. It's important to understand the evolution because sometimes we look at what we have in modern technology and we kind of look down on what was done in the past. I want people to understand what was the necessity of the past and why that was important. What was driving forces of our profession to get into implantology. So we'll see what they did. So the transosseal implant was the first implant that was come up with. The concept of osseointegration, which we'll talk about, was obviously not yet discovered. So how am I going to get a pin to fit into place to hold on to? And what was needed at the time, the biggest need was the lower denture. When you had people went into dentures in their late teens, early 20s, was like, yeah, totally normal for people walking around with full dentures. And we know now that it's not so much aging that's causing that alveolus to resorb, it's the pressure from the denture. So the patient wears an RPD, wears a full denture, there's going to be a price to pay because that alveolus will shrink over time. So now they're 50 years old and they have no lower jawbone to speak of. How am I going to get an implant, a denture to stay in place? So the concept of a transosseal implant, it was literally a screw. They went all the way through the jawbone and they went to the symphysis because of lack of vessels in that area and nerves. And there'd be a nut or a plate on the other side and they would just screw it in. As you can imagine, it had a very high infection rate, but it solved a purpose. You get 2 pins to be able to latch a denture onto, and it was very effective. Again, very high infection rate, so it never really took off, but when it worked and it worked well. Then we moved into the subperiosteal implant. And again, this is not an implant in the sense that it's being implanted into bone. This is a little bit different. What's done is a large flap is laid. An impression was then taken of the jawbone. They would then cast a framework. Patient would come back the next day or a couple days later. They'd be anesthetized again, open the sutures, and place this framework literally on the jawbone. It would have these little sprues that would stick out, and those would latch onto the denture. Again, it was a great concept, but as you can imagine, a very high rate of infection. This is what one of those framework would look like. This is the process of how they would take it and fabricate it, cast it, seat it, suture up, and be able to sometimes put a fixed case on these, and they were great. But, and I've even seen a couple of x-rays people have sent me. I've never seen one myself. Someone's come in with a subperiosteal in their mouth, but these have been done, I think are still done in some areas, and in some severe situations that you'd require a year or more of bone grafting. This may be an option for some patients. And I don't know if the sterility of, now we don't have to take a direct impression of their mandible. You can segment out their jaw from a CT scan and fabricate it that way as well. And I don't know if we're seeing low rates of infection. I still know it's certainly not mainstream, but I know it's still done. And this is one on the maxilla. And again, it's great when they work, but when they start to fail, they fail slowly and they fail badly. And a lot of times patients know that if they lose this, they have no teeth. So they will fight, no matter how much infection is there, to not have it removed. And again, you see all over the place, tons of pus, bone loss, loss of tissue, just really a real mess when they don't work. And we're trying to minimize our complications. So anything which has a failure rate of more than a couple % is really not something we want to do as a standard procedure. Then came along Dr. Brandemark, and he came up with the brilliance of osseointegration. And it was one of these findings which was, kind of a mistaken finding. He was not looking for something to latch onto, to hold on for teeth, or even to hold on to bone. It was a totally serendipitous finding of, he was using commercially pure titanium. He was testing microcirculation of a rabbit tibia with titanium device. And I've heard that the reason he used a titanium pin to hold it in was just what they had around. It wasn't that it was really on purpose. Stainless steel was a standard. For some reason, he just had a titanium device with some titanium pins, and that's what he used. And he tried to remove it, and he couldn't. It was stuck. Normally, it's the stainless steel. You give it a small twist, and it pops right out. But titanium was not coming out so easily. So some people would just pull harder, and you get it out. But he saw that it happened once, happened twice, happened 3 times. Okay, what is going on here? So the scientists in him started looking into why is this happening? And we saw that titanium in some way fuses to bone. And we'll talk about what it actually happens. They didn't really understand it exactly then, but they saw what was happening. So then they started coming up with different types of endosteal implants. So first they came up with a blade, then they came up with a cylinder that got hammered in. The blade also got hammered in. You can still see YouTube videos of Lenny Linkow of blessed memory. He passed away a couple of years ago. He was one of the pioneers of the blade implant in New York. I had the honor of meeting him. He still was lecturing about subperiosteals and blades when I was in residency and saying, you guys are overusing the screw implants. These blades and subperiosteals really still have a good place in dentistry. And when I saw that, I kind of looked at it like it was so archaic, but then I really started to go back and understand what they went through and what their needs were, and you can understand the brilliance of what they were doing. Good. And you have these pins, and I still sometimes will see patients that have these and are still in function. And the idea of the 3 pins was to try and tripod around the nerve to not go directly into the nerve. And again, you can imagine that's a big friction to deal with, but when they work, they work. Again, pins here, this is a case of a kind of a hybrid where they were first starting the osteal implants of screws, and they had some pins and just trying to get things to stick and throwing everything at it and just seeing what worked. And that was kind of the wild, wild west of implantology in these days. And you have these transosteal implants, or I'm sorry, these, I forgot what you referred to these discs. The way that these are placed is you actually lay a large flap, drill into this buccal part of the bone, the shape of these implants, and then hammer them in. The idea is just, it's working on mostly mechanical stability, but you'll get some osseointegration here as well. And you can see the small discs were made to fit underneath the sinus, the larger ones would fit into larger areas. And again, really good ideas, just they're not as predictable and much more traumatic than modern implants. And here's a blade, and you can see this is a digital x-ray, so it's still there in the modern age. So again, it's still, there's some of things are still kicking, but I don't know, correct me if I'm wrong, if anyone's still placing blade implants today. Any show of hands of anyone who's placing blade implants? Okay. Or if you know of anybody who's placing blade implants, none that I'm aware of. But it's a good concept. Okay, just a quick review of how is osseointegration working. So we talked about mesenchymal cells. We talked about how they differentiate into osteoblasts and fibroblasts. And those are two main bone cells that are the ones that are laying down new bone, the ones that are removing old bone. Those are the two that are most important. We talked about last time that the mesenchymal cells will also differentiate into fibroblasts if there's micro movement. And that's why the implants need to stay stable. That's going to be critically important. When we talk about early loading of implants, that's your biggest concern. We want to make sure that the osteoblasts have already done their job, because if they have not yet, those mesenchymal cells will not turn into osteoblasts. They'll turn to fibroblasts, and we'll have a fibrous encapsulation of the implant. I'm just going to skim through that quickly. This is what we had done in part 1. Go back and you can review there. This is what we talked about in part 1. I'm going to go through it quickly here. So osseointegration was first defined as a direct structural and functional connection between ordered living bone and the surface of a load-carrying implant. And what they saw was they would place the implant, and that would be day 1, make the osteotomy and put the implant in. And then what will happen over the next several weeks is that you're going to get new bone healing into that micro gap and forming a direct connection against that implant. And what's actually happening at a microscopic level is that this is a bone cell laying down on the surface, on an electron microscope surface of an implant. If an implant was truly smooth and was smooth as glass, you would never have osseointegration. The only reason that it works is because there is microscopic, small divots inside this implant and things for the bone to latch onto. There's no fusion really happening here. There's no chemical fusion between metal and bone. What's happening is the metal also forms an oxide layer, and this oxide layer has these little crevices all over the place that new bone will form into. When the new bone grabs into those little crevices, it forms a physical connection between them. It's going to be very difficult to separate, but it's not a fusion per se. So they redefined the term that it's a direct and functional connection between ordered living bone and the surface of a load-carrying implant at the light microscopic level. They realize there's no fusion going on. If we look at it under a light microscope, we see that that there is a direct connection, as we saw in this picture. When we look at under a electron microscope, we see it's not a direct connection. There's definitely space between the implants. And we look at any of the literature talking about the stability of implants, the term that's used is called bone to implant contact. How much bone is actually touching the surface of my implant that's latching onto it? And that's going to be what's going to determine the strength of that implant. And that's how the implant surfaces evolved over time. So machine surfaces had a roughness of about 0.2 microns. It's shiny to look at, and that has very few crevices. Still microscopically enough crevices that bone can latch onto it. But those implants, their stability was much, much less than our modern implants. So once we realized what's going on a microscopic level, we said, okay, if this is good, and this is what is latching onto bone now, and this is how bone is forming on the surface of a titanium implant now, that's great. Why don't I roughen up the surface and create more of those little divots for the implant, for the bone to hold on to? And that's where we get into that idea of the bone to implant contact. We're going to increase our surface area, and we're also going to increase the amount of bone that could grab onto it. So the initial ones, the initial cylinders, they had two issues. One, it was a machine surface, so it did not have very many crevices, enough that it worked, but not that many. So in softer bone, they had a very high failure rate. But also, when you put threads onto the implant, you've increased your surface area significantly, because now it's not just a cylinder. Each cylinder has threads coming out of it, and each thread has more metal surface for bone to grab onto. So it's going to create much, much more bone to implant contact. And then, again, the same way as we saw with bone grafting and with membranes, that companies just come out with ideas of what works, and then over time, you'll see studies will be done of what works better. And every company will trademark what they do and tell you that it's the best for reason X, Y, and Z. But again, if they were really the best, we would all have papers on why that is. And as soon as that patent would be lost, everyone would do it. The fact that nobody else is doing it now means that it really is not that much better than anything in the competition. So the way this works is they're going to inject titanium powders into a plasma torch at a high temperature, and you get now, what we talked about 0.2 microns, now you're getting to 40 to 50 microns thick. So that's a lot more surface area. And you've got about a 7 micron depth as well. So you've got a lot more surface area involved. And this is just, again, under electron microscope, where it just looks like a gray surface to us. This is what's really going on inside. And there's the grit blast technique. And again, I'll just run through these because it's more of the same. Sand etching, sand blasting, active fluor, they're all just creating surface area. And our nano surfaces. And again, they're going to show you machined versus micro etched, and you're not just getting a greater quantity of bone. If you look at this closely on the right hand side, you're also getting a much better quality of bone. That bone is much denser around those threads. So not only are you getting more, you're getting better. Yes, 3 weeks, here's at 8 weeks. You're seeing much more of that woven bone. This woven bone over here is much stronger and denser than just bone cells up against it. But then we realized sometimes, so there was a race to get as rough of an implant as you could. But then sometimes when does rough become too rough? What we mean by that is that there's a possible link between, and I could even drop the word possible, it's a definite link between peri-implantitis and the more highly roughened surfaces, because polished scholars, and we talk about hybrid surfaces, and that's where just the development of different kinds of surfaces comes from. But what I want you as the doctor who's ordering the implant that you like to understand is what is happening in your given situation, and where are you going to place your implant based on its surfaces? What is it intended to do? So this is kind of an evolution of different implants. And you saw at the beginning, when they left these holes through them because they thought the bone would grow through them and give it an extra lock. That kind of fell by the wayside because sometimes we have enough stability from implants nowadays that when you need to sometimes remove an implant and you got bone growing through the bottom and it's locked in, that's not going to be much help to anybody. So you can have bone loss all the way down to that little hole and still have a really tough time removing the implant because it's really locked in that tight. So with osteointegration, you have to respect and understand the biology for things to work well. We want to use a minimally traumatic surgical procedure. We want a high primary stability because we talked about that 10 micron movement will cause those fibroblasts to come rather than the osteoblasts. Okay, I'll talk again in a small group. I'm happy to talk much more about surfaces and your specific implants that you like and why, what the pros and cons are about each one. There's no perfect implant out there. Each one is meant to serve a specific purpose, and you have to know what your purpose is and if that implant is going to fit that. And if you're using like a specific company, understand why they designed it that way and how to place it best to get your best results out of that implant. Okay, but we'll go into more detail another time. When you're treatment planning your patient, we're going to go through our medical history. I'm going to skip through this a little bit quickly because, again, this is more case by case. We'll go through if you want to present a case. Okay, we talk about vitamin D is an important element in implantology. Some of the bone disorders, bisphosphonate drugs we talked about in the previous lectures. Here's some of the names, and there are more and more names coming out all the time. We talked about Merange or Bronge, as was formerly known. We're going to kind of skip through this now. Happy to talk about in greater depth later on. It's just some of the biology of what's going on. This is clinically what you'll see is an extraoral fistula, some messy situations. I'm going to just skip through these quickly. Where does implant maintenance? This is one of the biggest issues, and I talk about it now, even though we're just starting to talk about implant placement, because if an implant is placed properly, it's going to be really easy to maintain. If an implant is placed poorly, no matter what you do, you're still going to have constant irritation and continued bone loss. So the most important thing is placing it ideally. We talk about how much bone you want surrounding it. It's a 1 millimeter standard, but I'm always looking to make that as much as possible. I want there to be as much bone surrounding that implant as possible, because it's not the implant really that's anchoring the tooth in. The implant is the bridge between the jaw and the tooth. So if you have a very big implant in there and you have very little bone, that's not a lot of help because the bone needs to be strong. As important, if not more important, than the thickness and strength of the implant. And then we're looking here at, this is a CT view of a patient. This is the cross section of the missing tooth. And what I want you to appreciate here is we're looking at, we can measure 6.1 millimeters of bone at the crest. And if we place our implant at the crest, those are the numbers we're going to work with. We have to subtract at least 1 from each side to leave our enough bone. And now we're down to a 4 millimeter implant. And in a molar, a 4 millimeter implant may be a little on the smaller side. And 6 millimeters of bone at the crest is pretty good. Many times you have significantly less than that. So I want you to understand is there's cortical bone and there's cancellous bone. And we talked about and that's again, that's that same, there's a hip joint socket just showing you what cortical versus cancellous looks like. So when you look at the bone in a cross section, so appreciate what is going on here. The early days of implants, you wanted to get cortical stabilization. The implant was stabilized in the cortex, and that was really important because it was a machined surface, and if you didn't have really strong bone around it, you weren't going to get a very stable implant. Nowadays, when we have much better surfaces, we don't really need cortical firm bone grabbing onto our implant because our cancellous bone will do a very good job as well. So nowadays, we couldn't do before. Nowadays, we can put our implants deeper. And that will give us several advantages, which we're going to talk about, not tonight in a lot of detail, but just realize you can place your implants subosseous, and that's how most implants are designed nowadays, and still have just as good a stability without a lot of the issues of leaving those rough surfaces near the crest of the bone where bacteria can attack it. So we're going to place our implant subosseous, and again, we want to make sure that we're burying that rough titanium deep in the bone where it will never come into contact, ideally, with bacteria. So about 2 millimeters ideally of space, and again, we're going to have a greater availability of blood supply to the bone because with 1 millimeter, if you're only leaving the walls, which are the cortical walls of bone, cortical bone does not have great blood supply. And now you're putting an implant which has no blood supply. So if you continue to choke off oxygen from those walls, they're going to continue to shrink also. If you leave a lot of space, then the body has plenty of room to flow oxygen around your implant, and the implant will stay in there very well with minimal bone loss. So I mentioned here, what if 2 millimeters are not available? And that's also part of your workup. Don't just say, this is what the bone is, this is what I have to do. There are always options of adding additional bone. Sometimes it's really easy to do. Sometimes it's a little more difficult, and it could be out of your skill range, but don't limit your patient's outcomes by your current skill level. If you know it could be done better in someone else's hands, and they need something more than you can offer them, don't just not offer it to them, then refer those cases appropriately. But you have to know and understand what can be done for that to work. So I'm just very briefly going to skip through this case quickly, but this is a ridge split case using a piezo, just creating out of an initially a very small amount of space, we can create a lot of space in the maxilla and oftentimes in the mandible as well. Where I started off with about 4 millimeters of bone, these implants themselves are 4.3 millimeter implants, and I've got a good 2 millimeters of bone on each side at the end. So we've increased our overall volume of bone by about 4 or 5 millimeters by doing a ridge split procedure. And it was, again, very easy to do. And again, it's kind of next level. So you'll choose your cases appropriately. That will make sense that you can get your best implant in without really hard extra procedures now. And then down the road, once you get better at implants, you add more and more to your repertoire. Proper spacing between teeth and implants, also critically important. Snap a screenshot of this. This is your easiest way to know how much room you need to leave yourself. The general rule is you want to leave 1.5 to 2 millimeters of space around each implant. So next to it, between a tooth and an implant, you need 1.5 to 2 millimeters of space. It's again because the implant has no oxygen source, no blood supply. So you need to leave it enough room to have blood flow around it. A tooth, on the other hand, has its own PDL and it has its own vasculature inside the tooth. So it doesn't need nearly as much space around it than around other structures. But when you have two implants next to each other, you have to double that number because each implant needs about 1.5 to 2 millimeters of bone around it. So when you put two implants next to each other, you need to leave proper spacing there. Also proper spacing to the nerve, at least 2 millimeters of treatment plan to get yourself out of trouble. And nowadays with CT scans and drill stops and certainly with guides, it makes your life so much easier. And you also want to leave yourself enough prosthetic space. That's also critically important. Oftentimes overlooked when you place the implant, you didn't have enough prosthetic space, and now you go to put a crown on it, and there's just no room to have a decent emergence profile. This is when spacing was not respected, and you end up with a giant mess. And those implants need to be removed because two reasons. One, how are you going to get two crowns on here? But even if you did get two crowns on them, you're going to have a giant gap to fill on the distal and no space to create anything real on the mesial. So it's going to be just a messy case. That distal implant needs to be removed and replaced about its own width, its own diameter over more distally. And again, if you realize that, and you see the anterior one wasn't placed very well either because it was coming out of the buccal plate. But if you realize that early, and once you place it poorly, you can always go back and take out the implant and come back again later. There will definitely be times that you will place implants, you look at it and say, that's a piece of crap, I better do that again. And you're always better off taking it out and letting it heal and coming back than trying to leave something poor in the patient's mouth, letting that integrate and now having a much bigger mess to deal with later on. Again, implants placed too close to each other, not enough blood supply getting through there. The bone is going to resorb, and you're going to end up with a giant mess. And again, these are restored. This doesn't happen quickly. This happens slowly. But when it happens, it's going to be a giant mess to be able to fix. This is what I call the quilt way of going about placing implants, where a patient comes in and is missing needs a tooth replaced. So replace it. They come back, they're missing another one. Put in another one. They come back, they're missing another one. Put in another one. Before you know it, you have a mess like this. So once a patient is missing a couple of teeth, you have to start to plan big picture. And sometimes you'll sacrifice a tooth to be able to put a proper implant restoration if you know the tooth's going to be lost in a couple of years. So it's always big picture thinking rather than just see a hole and replace it with an implant. Again, greater availability of blood supply when you have proper spacing, both between the tooth and the bone and the implants and each other. And then we're going to talk about soft tissue. You also want a nice soft tissue cup. That's also one of the most overlooked things, in my opinion, in implant dentistry today is soft tissue adherence. You want enough keratinized tissue around the implant. And again, I'm just going to skip through this quickly. You want a 2 millimeter cup. I'll talk in great detail about the importance of this. To me, this is a difference of knowing from the day you restore the implant if it's going to last a lifetime or it's going to last you about 5 to 7 to 10 years and then be a mess to clean up. Why, when you take off healing caps, do you want to see bleeding? I'll talk about that in greater detail later. We're going to skip through that now. The fibers that are around teeth versus around implants, you have basically one fiber around an implant. So you really want that seal to be excellent. It can't just be okay. It's got to be excellent. Otherwise, bacteria will just get down to the platform of the implant right away and start to cause bone loss from day one. And again, I'll go into much greater detail in this later and the biology of that. If you'd like, here's just some cases of when you know things are going to go well, difference of how a tooth can deal with an inflammatory process and how an implant is defenseless. So you have to give it its greatest defense to make sure this doesn't happen. The stage 2 procedure, I'll just mention this briefly because I think if you're already doing implants, this is one of the single easiest things to do for your patients that will make a critical difference in the outcome. So when you look at this area, so I have my implants placed already. First thing I'm going to look at is where is the attached tissue now? So I'm going to move the patient's cheek and I'm going to feel and see where is the tissue mobile. I can also inject my anesthesia and I can see where the tissue lifts up. That is mucosa. That's not attached keratinized tissue. That tissue is very poor around implants. I want thick keratinized tissue. But the good thing is the soft tissue heals really, really easily. And with a simple change of where my incision is going to be, I can turn this where if I just made a mid-crestal incision, I'm going to have mucosa on the buccal completely. So I can make a palatal incision and push a ton of soft tissue over. And I get oftentimes asked, look at this large amount of bone I'm leaving exposed in the mouth. That's going to cause an infection, isn't it? No, it will not, because that will clot up very quickly. And within 2 weeks, that entire space, in as short as 2 weeks, it fills up with brand new attached tissue. This is no extra grafting. This is just allowing me to place my flap towards the buccal. I make my incision towards the palate, push that tissue over, and let it fill in on its own. And I love this picture because I don't do this anymore. I'm a little more careful than I used to be. If you look at my sutures here, on this mesial implant, I have attached tissue pushed over, but I sutured it back over top of that implant. So on the most mesial part, if you can see, I'm going to get mucosa to heal. There are not proper attached tissue. What I should have done is taken this part of the flap and not sutured it back to the palate, sutured it across on the buccal side. That still would have filled in, and this corner of the flap would have then been much higher in the buccal, would have all filled in with attached tissue, and that would have had a perfect case. Instead, I have amazing results in the posterior and just okay results on the anterior one. The distal of it, it's fine. The most mesial aspect of that mesial implant is deficient in terms of soft tissue. And again, that's where, in that spot, bacteria can leak in and start to cause a mess. When it had attached tissue, you very, very rarely have issues with bone loss around implants. And this, again, this is a situation that's ready to be restored. But if you look, there's mucosa on the outside, it's going to be a mess. So in this case, we did a free gingival graft because we want attached tissue there. But nowadays, what I would do is remove those healing caps, let the tissue granulate in again, make an incision through the band of attached tissue, and it could be as little as 1 millimeter thick, and I can make that to 6 millimeters thick just by my incision. You've got to bisect that attached tissue perfectly, put wide healing abutments in. I even sometimes put temps in, push that tissue all the way out. Everything that fills in between is going to be new attached tissue. And I remember we talked about yesterday that the idea that epithelium can't grow in except from the borders. Just like you have a scab that grows in from the borders, as it heals, same way as the tissue, the same principle going on here. As you're bisecting that attached tissue, so let's say I'm looking at the screen here, I'm bisecting it this way, putting in my healing abutments, let it stay there, and just a couple of regular sutures, let it hold open, and all it will granulate back in with new attached tissue. So I'm very rarely doing free gingival grafts nowadays because, again, it requires a donor site, and it's really not as predictable as doing it just by bisecting the tissue. Good. Just a matter of which one of those would you rather restore. Again, I'm going to move a little bit faster here. Restorations have to be really well contoured. We have to place our implants deep enough to be able to get a reasonable emergence profile. If it's going to be too crestal, too coronal, and there's not enough space for the lab to create an emergence profile, you're going to have a food trap set up the day you put in your restoration. So it has to be placed properly and then allow the soft tissue to form. And again, I'm going to skip through a couple of just clinical cases of how to create that and how to create ideal tissue. Okay, here I talk about cement, and cement being an absolute killer to implants. I just want people to understand, just to show you quickly here, when you have a little piece of cement and you think that's just a little puff, you know, at the end of an endo, that's fine. But this, it can cause one little piece of cement is all you see in the x-ray. But when you look at it, that's what it actually looked like in the mouth. And you can't see that because that soft tissue attachment is much, much looser than a PDL on a tooth. You can overfill a crown on a tooth however much you want. It's never going to push all the way through that space. It'll harden. You just pluck it out of the pocket, and you're great. Implants create this deep pseudo pocket we create on purpose, but cement can easily push in there. And here's just another example where it looks like a little puff of cement, no big deal. This implant ultimately was lost, and that's what's actually around the implant. This was cemented, pushing cement all the way down the surface of that implant. Again, it had bone loss when it was cemented, obviously, but that's the mess that we see clinically versus just that x-ray there. That's the difference. So what we want to do is just very, very lightly brush our cement in. In a prosthetic lecture I give, I talk a great length about advantages of screw retained and doing that whenever possible, but sometimes cement is the only option. So it's got to be very, very careful the amount of cement you have. There's a lot of tricks to be done to minimize the risk of cement, but the most important thing is you have to just see it and clean it out when you see any drop on an x-ray. Okay, so we're in home care being critical. Want to make sure we're lowering our bacterial loads as much as possible. That's also really important. And again, my maintenance, we talked about a little bit in the beginning. I'm going to skip through that just in deference to time. We're already 5 minutes over. Parafunction, we want to diagnose that early. This is a fractured screw. Aesthetic expectation we talked about. Good, we talked about this a little bit. Make sure we plan our case properly. And happy to do that together. Knowing your landmarks, knowing what happens. This is on a CT scan. On a PA, you'll oftentimes miss this, the sublingual fossa. But on a CT, a post-op CT is not where you want to see this. It's a pre-op CT, so make sure not to put the implant through it. This is actually one of the very, very few instances that an implant surgery can cause the patient to have a life-threatening complication. If you put the implant through this this submandibular fossa, the lingual nerve and artery oftentimes run right through there. So if you drill too deep and puncture through this area, you're nowhere near the inferior alveolar nerve, but you could rupture the lingual artery. The problem is the bleed has nowhere to go because you've just filled that space out with an implant. So the only space it has to go is down into the airway. And that can very quickly turn into a medical emergency. And there have been documented cases of patients dying from that exact complication. So you really want to make sure that that is not something mistake that you make. Before the explosion of CT technology, there are tips and tricks to be able to see where that fossa is, not to get into this problem. But nowadays with the CT, it's just clear as day. We'll talk about the implant spacing. I'm going to just run through this a little bit faster. The radiographs, just documenting what's there. And just go through this a little bit faster in deference of time. And again, making sure that you don't leave anything behind in your exam. You're very thorough. This was a case that I had sinus lift and 2 implants for a 3-unit bridge. Everything's going swimmingly well until the patient came back with this, and it's on a little old lady. And I said, how did you break the implant head? This is not just the screw broken, this is the implant head broken. I don't understand how this possibly could have happened. So, okay, we get her numb, we open it up, we're gonna take out the mesial implant, thinking the distal implant's gonna be fine. And we find is, look a little bit closer, the distal implant had a dark area around it. So how this actually happened was this completely deintegrated, put all the stress of a 3-unit bridge on the anterior implant, and that's how it broke. So this is how she walked out of the office that day. I placed a mini implant just to be able to hold on to a partial flipper for a little while. What we ended up finding was, let's see, what was this case? We had the implant deintegrated. Why? Because of this distal tooth. I did not diagnose this distal tooth well. The infection here spread over to the implant. Again, asymptomatic on the tooth. That's separated over. This was how I left my post-op. This tooth, though, did have a lesion. I went back and looked at the CT scan. It did have a lesion then, and that spread over. And again, it'll spread faster to an implant than it will on a tooth. Significant bone loss, and then loss of the implant, and then loss of the whole bridge. So I want to make sure that the adjacent teeth are healthy. I want to make sure that no adjacent roots that are remaining there. If you see them on a CT or a PA, make sure they're removed before. And that's just that same root being removed. And I could see why someone forgot that piece of the root there because of that hooked root. But don't just leave it there. Still, you got to remove it. Because if you don't remove it, someone else will have to at some point. Okay, case selection. That's going to be one of the most important things for success of implants in your practice is proper case selection. Make sure you're doing things that you're going to be totally comfortable with handling, not something that's going to be way over your head. And that's what we're here to help you decide which are those. Okay, grafting, orthodontics, I'm going to skip some of these cases because this is a case-by-case basis. Sinus augmentation, I'm going to skip through this quickly. Also, this is a lateral lift when necessary. Let's skip through this quickly. Okay, again, our pre-surgical planning, we want to make sure we have our thickness of bone properly, depth of our anatomy, how much room do we have to work with, how much room are we leaving buccolingually and between the teeth and between the implants, and how deep are we going to place this implant for the crown to work. This is an old school surgical guide. Now I'm 3D printing them right here on these printers. Again, our cartilage used to be 2 to 3 millimeters apical to the proposed CEJ of a tooth. Write that number down. I think this is also a thing that's overlooked greatly. Implants are placed oftentimes way too coronally, and we get into problems after the fact. So plan where your new tooth is going to go first, and then make sure that it's going to be 2 to 3 millimeters apical to that CEJ of the tooth. If you follow that rule, your lab will always have enough room to be able to place a proper crowd. You also have to make sure that they're going to do it. You have to plan and make sure with your lab that they're not just going to give you a very, what looks like an apple on a stick, a very thin neck, then it hit the top of the tissue, and then it becomes a big crown, like a mushroom. We want it to slowly emerge out of the tissue like a tooth normally would, because if they just give us a mushroom, we're going to get food getting stuck underneath it all the time. So that's a really, really important point. Once again, easily planned in advance. Good. You want to leave about 1 to 2 millimeters of flare in the gingival emergence to be able to get that ideal emergence profile. Okay, now getting to the pre-surgical planning. We want to obviously get an informed consent, pre-op blood pressure, provide our prescriptions. I provided prescriptions in advance. These are my standard prescriptions. So they're going to get an antibiotic. I always have them pick up the prescriptions in advance. No one wants to go to the pharmacy right after they had a surgery done. So give it to them at the consult so they can pick everything up and have it ready day of surgery. The antibiotic, again, the Paradex we talked about yesterday. Why do I prescribe Paradex? It's not a magical potion. It just is a prescription to help them to tell them to clean it. I give a prednisone to most patients, along with 600 milligrams of ibuprofen. Two of those do a great job in slowing down or eliminating the swelling process from ever happening. No swelling, no pain. So if they take those two in conjunction with each other, they will work well. Obviously, they have to be able to take those medications. Diabetics could be a problem. So just check with the patient, make sure that these are all things that are not contraindicated to their medical history. But it's a great side advantage of just decreasing the amount of swelling. It will not change your outcome, meaning either your integration will work or not work, irrespective of that medication, but just their comfort afterwards will be significantly greater. What you need in your setup, again, everyone's going to have things a little bit different, but basically you need a scalpel, a nice periosseal elevator, perioprobe, either Minnesota or some sort of and there's some peri instruments that can replace that. Your implant placement kit, obviously, and the implants that you'll need, which we'll have selected in advance. Your motor, healing abutments, needle holder, suture, and scissors. That's your basic armamentarium. And that's a setup that I'll use. It's in a cassette. I like to keep things in a cassette because then things don't get lost. You don't want to be searching for loose instruments during procedures. I also have a checklist, which I'm happy to share with you guys before every procedure I do. This is what I need out. And it's going to be things that I need in 95% of cases. I may not use everything, but I'd much rather have it out in a sterile bag on, just behind the surgical field that I can grab, rather than saying, oh, I need this now, and having my assistant need to take off her gloves, go into a drawer, find it, bring it out. It's a killer of time. Take everything out that you need early, and you save yourself a tremendous amount of time and frustration. That is the periosseal elevator on one side and a Pritchard paddle on another. It's great to be able to reflect the tissue and then hold the tissue back with. Day of surgery. Again, you have your informed consent signed. They could do that at the consult or at the day of surgery. They're taking their antibiotic. Sometimes it could be pre-op, it doesn't have to be. Sometimes it could be post-op, but I like them to have it there to have taken it that day. May as well have taken it just as we're starting. 30 minutes before the procedure, studies show that an NSAID reduce the inflammatory response from your initial incision. So when they get to the office, 30 minutes before that incision, you're going to be about 10, 15 minutes of anesthesia, of consent, another couple of minutes. So about 15 minutes when they get into the chair until your incision happens. So when they walk into the office, 15 minutes before that, it's a good time to take their NSAID. Paradex rents, again, before, again, it's not imperative. It's just a nice little adjunct. Local anesthesia, block versus infiltration. We can have a long conversation about that. I'm going to skip it for now. The crestal incision, again, I'm going to want to bisect the tissue, as we just talked about, much more than making it through the crest. Crest is not such an important landmark. Bisecting that attached tissue really is the most important point. Just show you a case here. Tooth was taken out, areas grafted, graft heals. Those are some larger particle grafts, as you can see. Everything healed up nicely. Make my incision. Here we have an abundance of soft tissue, but I still want to push out the tissue on that buccal to mimic a root space that's there. Importance of a starter drill. This is really one of the most important things. I see a lot of kits come with a round burr for your first drill. Round burrs are tough because it's round, and when it starts to spin, it can jump on the ridge. I want something that's like a spear. I can push into the ridge where I want to start drilling before I ever engage the handpiece and start spinning. And that it's not going to move. So I push into the bone with this really sharp drill. That will start to puncture into it. It's all lance drill. Then when I start spinning, it's going to go exactly where I want it to go. We're going to avoid heat with copious irrigation, good drill speeds, and very sharp drills. Initial twist drill is going to give us our length and monitor our angulation. So again, a freehand surgery rather than a guided. We'll talk about guided in another lecture. Remove it, and always a good idea to take an x-ray. I'm doing it less and less with guided surgery. If everything looks good and my first drill goes in where it looks like exactly it should be, I'll proceed. But in the early years that I did this, first few thousand implants, I would say, I took an x-ray with every single one on the first drill. And I'll put a pin in there with some floss tied to it. And the floss, assistants always will waste our really, really expensive things and be very stingy with our very inexpensive things. My assistants used to give me like a strip of floss this big. Floss is really expensive. Give it to me in arm length, because if the patient swallows this, the point of the floss is that I can grab that floss. It's a tiny piece. They've swallowed the floss also. That's not going to be helpful. I make it long enough that I can, when we leave the room to take an x-ray, I clip the side of the floss to their bib. So it's not going anywhere. If it dislodges and it's swallowed or aspirated, it's easy, pluck it right out of their throat, and we have no issue. If they swallowed it, or God forbid aspirated it, it becomes an emergency. So I'll see my first drill is leaning a little bit towards the mesial. Okay, so when I go deeper, I'm going to correct that angulation and take as many x-rays as you need. As you're drilling, oftentimes there's extra bone on the end of the drill. I oftentimes, if I feel a need, I may want to graft around the top of the implant, harvest that bone, have a little dappen dish out, have my assistant scrape that little piece of bone off, or I'll do it myself, into a dish and save that bone to be able to graft around it later. My osteotomy is made. I may need to use, in denser bones, again, you'll need to drill a little bit more versus less. Something really soft bone, I'll under-prepare the osteotomy, and you let the implant itself tap its way in. But again, wait till you get more experience doing that, till you get a kind of a feel for it. In the beginning, just open it up to what it needs to be and place the implant. Even if it'll have less stability from go, that's okay, it'll get there. Again, the stability issue, which we'll talk about soon, is more of a stability over time versus stability today. I need it to be snug. When I tighten it in, I want my fingers feel tight, but I don't need to have very high torque value for this to work. Again, one stage versus two stage. We could talk about this in great detail. Also, you're never wrong for doing it as a two stage, for putting a cover screw, suturing, and coming back. Oftentimes, you'll avoid a lot of headaches by not putting healing caps on right away. Nowadays, I'm actually taking a digital impression of the implant as it goes in. So my second stage surgery is already with a temporary crown. I'm not even using healing caps for a lot of cases. So that saves me an entire visit, and the soft tissue is much, much better than it ever would have been with a traditional healing cap. But I could talk about that in greater detail later as well. Implant stability just needs to be, again, stable so it's not going to move during the healing process. It's going to get weaker over time due to the osteoclasts for the first 6 weeks. I need it to still be stable 6 weeks later. That's the goal. And again, we talked about this already. I'll skip through this. This is a really important graph because it will show us that of what our total stability is. on day one, let's say it has our let's say a 72 on an Ossel machine, which is very stable. I'm going to get a drop off of that for the first 6 weeks. And that's my mechanical stability is going down, because it's not just the pressure of the implant against the bone, because that's going to go away. Osteoclasts are going to take the old bone away, and my osteoblasts are going to start to build new bone. That's my biological stability. And that's going to start to go up over time. Where those two cross, where you see the red and the blue lines cross, is where my total stability is at its lowest point. Then my biological stability takes over and my total stability goes up. This graph is a little bit misleading because you actually tend to be much stronger at the end than you were in the beginning. Here it's assuming that you're getting back to 100. You really are starting off at like a 60, and then over time you're getting to 100. So you're going to get much higher later on, because our biological stability is what's really holding us in. And again, this is the day one mechanical stability, and then once it heals, that's our biological stability. Okay, this is torque versus the ISQ. If those of you don't know what an Ossel machine is, we can go through this in great detail later, but it's just a way to objectively get a sense of how much stability the implant has on day of placement versus down the road when I'm ready to restore it. And it's just some of the details of that. I'm going to skip through here. If you want to grab a screenshot of that quickly, it's a helpful chart to have, and I can email it as well. Just shoot me an email and I'll send it back to you. This is our implant sutured in with a healing cap. This is the second case. Again, I'm pre-planning my tooth in advance. It looks like I have over 10 millimeters of width of bone here, but that's not all usable bone. The bone that I need is going to be the one supporting where that tooth is going to go. I'm not putting this tooth in the center of the bone. I'm putting that tooth where it needs to sit in occlusion. So I'm not measuring the 10.7, doesn't mean a heck of a lot to me. The 14, .9, the 15 millimeters to the nerve, that's important. So I know I can put a 10 millimeter implant in without blinking. But the width there is not so important. My real width is going to be where the prosthetic tooth is going to be, and how much room do I have in that envelope. This is, I talked about a round burr. I don't love these for starters. I could do this for a second one, but my first one's going to want to be as sharp a lance burr as I can get my hands on. You can even use a high speed if you'd like to make your initial puncture through the cortex. Again, you place your initial pin, take an X-ray. Here I'm kind of tilting over, and I like this this X-ray because if you see, my septum of the socket is still clearly visible from my graft. The graft is still there, it's healing, but it's not quite as dense as the other native bone. So what's going to happen? I'm trying to put a drill into this area. Where is my drill, which is going to drift towards softer bone, rather than for a harder bone? It's going to bounce off the harder bone and drift towards softer bone. So where is that going to go? That's generally going to go into one of the sockets, and that's exactly what happened in this case. It's going well, except oops, now I'm pushing my drill way into the mesial socket. That's a little bit of a problem. I'm going to correct it here, and I'm going to put it back into a place and get a stability. If you look at restoratively, this is still in a good spot, but I'm still, that implant on the distal is going to have more room to have to close up that that gap on the distal. If I placed it dead center, it would have been a much better position. How do I avoid that now? So the easiest way to avoid it is to use a surgical guide, because it will force your drill into the right spot. But in lieu of a surgical guide, or even to make it easier, now when I extract the teeth, I will, if I'm not placing the implant immediately, I'm going to remove the septum. So why am I removing the septum? Because in 3 months, when I come back to place the implant, I want that bone to be uniform density. So I can place that implant easily dead center. If I don't, it's going to more often than not have me end up with a situation like this, where my implant falls into the mesial socket or the distal socket. Here was still restorable and was fine, just made it a little bit more difficult on the distal. Sometimes it creates a huge overhang. We've all seen implants like that, huge overhang. And you think, what was the surgeon drinking that day? Because how could they possibly place it so poorly? The answer is the bone density was very, very different. Just want to show you that picture again. Day that they placed it. and it forced that implant into the place that they didn't want it. And they realized when they closed up, that's not where they intended the implant to go. It's not like that they didn't even notice what they were doing wrong. They knew what they did wrong, but they just had a really hard time correcting it because that septal bone didn't want the drill to go into that space. And they said, oh, the general dentist will fix it with the restoration. And then it gets into your office and it becomes a giant headache. And then it's a matter of blaming the surgeon, and the surgeon is blaming you, and you're the one who put the final crown on that's annoying the patient. They left the surgeon and they loved the surgeon. He did a great job. They were in very little pain, so happy. They get to your office and you put a restoration on and they have nothing but headaches from it. So it's your fault. So make sure that doesn't happen. Place the implant yourself in the proper position, or work with surgeons who are placing it in the proper position. And the easiest way to avoid this scenario is the day of surgery, remove that septum, especially in mandibular molars. That's a really nice pearl that's very helpful. Okay, post-op, we're going to tell them to take their meds as prescribed. Similar to extractions, basically the same post-op instructions. Ice, gentle, no rinsing the first day, avoid hot foods, no smoking, obviously. Day 2 to 7, keep taking your meds. I tell them to expect to be in significant pain for at least a week. That way, if it's only 1 or 2 days, you're a genius. If you tell them 1 or 2 days and it's hurting them even a little bit, and they're taking a Motrin once a day after that, then what did you do to them? So tell them it's going to hurt for a while. Tell them to just kind of avoid the area. The peak of swelling is going to be 2 to 3 days. So once you hit 2 or 3 days, I then want to hear, is the pain getting the same, worse, or better since about day 3? And if I hear that it's getting better, even if they're in some significant discomfort, I will say, okay, I realize I'm sorry that you're in discomfort, but as long as we're getting a little better every day, we're going to be in good shape. 2 weeks to check soft tissue healing. I talked about, I do it actually now more 4 weeks, but there's nothing wrong with seeing them earlier or more often. Now we're talking about when are we going to restore this implant. If we're using an Ostel, we have an objective number to work with. Otherwise, what I used to do is the forward torque test, but I would always give more time. So again, my standard is 3 months for a mandibular tooth, 4 months for a maxillary tooth, just to compensate for the quality of the bone that's stronger in the mandible than the maxilla. And again, if you're forward torquing it and you're not using an Ostel, always give it more time, because if you forward torque it and it moves, now you've just set your clock back because your bone connections have just severed, and those need to regrow back to where it was the day they walked in, and then get even stronger than that. So don't look to restore things early unless you have an Ostel to check it. Always give it more time. It's almost much less headaches if you give it more time. Don't be in such a rush. Give it 3 to 4 months to heal at least, and make sure it looks nice in an X-ray. If it doesn't look good in an X-ray, just tell them. It needs a little more time. It needs to get there. If they're diabetic, if they're smokers, things will take longer to heal. So tell them that from the beginning. Talked about the ISQ briefly. Yeah, just when you uncover implants, especially when you're placing them subcrestal, what will happen is you'll go back and you'll lay a flap and you won't see the implant because bone will have completely covered up the top of the implant. Nowadays, we're using implants that have a conical connection. We could spend an entire lecture talking about connection types of implants, but the connection I use nowadays is a conical connection just about only because it seals out bacteria better than anything else on the market. The Blue Sky Bio Max implant does that. The Blue Sky Bio Conus implant does that. Those are my 2 favorite implants that I'll use. And when you go to uncover them, the only headache is that you have too much bone now. What do you do with all this bone? So Blue Sky has a fantastic kit for their Max line of implants that makes this a breeze. Used to be you would have to go with a high speed and kind of profile out enough space to fit your prosthesis. If you didn't do enough, you'd have to go back and do it again because your abutments won't fit. But they came up with this great kit that makes life very easy. You take the small pin, you see the pin, that's the pin is to our far left, you screw that pin into the implant. That pin guides these trephines around the head of the implant without ever touching the implant. So what used to take me 10 to 15 minutes now is done in less than 2. Screw the piece in, See, the abutment now is not seated because we have too much bone at the top. That's a good problem to have, but it could be annoying if you don't remove all of it. So you remove that abutment, you screw in this pin. You take the profile for the size abutment that you'll need there. And I usually start with the smallest and work my way up just to not traumatize the bone that much. It finds out exactly what we need. And now we can fit our prosthetics in there very, very easily. So this is the Blue Sky Bio profile kit. I believe they only have it available for the Max implant. I don't think they have it for any other lines. Michael, correct me if I'm wrong, but I think that's the case. Okay, post-op, if there's an infection, we'll talk about complications post-op, again, in a small group if we'd like. I'm gonna skip through it now just in deference to time. A lot of it is just avoiding issues to make sure we don't have them. That's most often the situation. Let's see, any really, really important ones. Yeah, well, if the implant is totally out of the envelope, what do you do? We can talk about that later. You place it like this, what do you do? So first of all, just don't do it. But again, you do enough, things will happen. What you don't want to do is place it too deep. You do not want a situation like this. This is just sloppy planning. You place the implant right into the nerve because you use a 13mm implant where a 10 would have been just fine. That's what we call a code brown. That's when the complication happens. You know what happened right away because the patient says, ow, even though they're numb. That means you got way too close to the nerve. First thing I tell people is get a fresh pair of pants. Verify what happened with a radiograph, exactly how deep you went. If it was an implant, remove the implant. If it was just a burr, obviously you want to remove that. You can consult with a surgeon who's going to help you out here because this is going to be a mess. You want to maintain a rapport with the patient. Worst thing is trying to cover it up. Worst thing is trying to say, nothing happened, everything's great. Don't do that. There was a complication. There may have been some damage to the nerve. We're going to see how you do. What I've seen is even when things look bad, oftentimes they will heal over time. It will take a lot of time sometimes, but things tend to heal. And then you want to track the dimensions of the paresthesia. It's also really important. They'll come out of the surgery and they'll say, it's numb right here, all the way down. Say, oh, that's bad. So you're prescribing, obviously, a post-op pain medications, but more importantly, you're giving them anti-inflammatory medications to keep the inflammatory process down to allow this some room to heal. If you gouged, took a burr and just went right through the nerve, they may never recover. But most oftentimes it's just nicking the nerve, and that oftentimes can make, at the very least, a partial recovery, if not full recovery. But we'll leave nerve complications for maybe some of the questions later. Post-op complications, bleeding, infection, paresthesia. Again, it should never happen anymore. Failure to integrate, and peri-implantitis. I'm going to skip through a lot of what we're doing with these for a case-by-case basis. What I'd like to stress is if you do enough implants, you're going to have a failure. It's just going to happen. It's the nature of what we do. I left residency after a couple of years and I didn't have one failure, and I thought that was a great thing. Did such a good job. The truth is I probably had some failures that happened after I left, but the first time I had a failure in private practice, I almost had to change my pants also because it was so shocking to see. But it's going to happen, so you have to be prepared for complications. As they say, we don't get paid for when things get well, we get paid to manage things when they don't go well. We want to remove all the infected tissue, potentially graft, and replace it. Again, it's not the end of the world. It just means it just needs to be replaced. But that's where you want to consult with someone to make sure what went wrong here and how do I make sure it doesn't happen the next time along. I just we'll end off with a quick case. This was if you're going to get into immediates, your maxillary premolars are your best bet. Mandibular premolars never, because unless you have a CT to verify that the mental nerve is nowhere in the area, don't even attempt it. Because it's oftentimes right underneath one of those roots. But maxillary, if you have room to the sinus, is a great way to go because it's really going to go straight up and down into the socket. So we talked about sectioning the teeth, atraumatic extraction of the roots, clean out the socket. We talked about that burr. Here's a picture of that burr. we talked about in the first lecture. That's what I'll use on a surgical handpiece to go into the socket and clean everything out really well. That's what our socket should look like. That septal bone is exactly where I'm aiming my implant to go. So I'll put my first pin, place the implant. I go to the distal site, and if you see the distal site, just the bone there was like a fatty tissue deposit in that area. So rather than just leaving poor bone there, I scraped out anything that was soft, still was able to place my implant, but then I'll graft that entire defect. So the defect was not a bony defect per se. It's just the type of bone that was there was like a little fat deposit in the bone, which will happen sometimes. So I'll take a spoon and just curette out anything soft. I still have enough bone to stabilize my implant and place a graft on top of it. At that bone carrier we talked about last time, a diabetic syringe with the end cut off. Put my allograft into the area. In this case, because I was getting primary closure, and we talked about this at length last time, because I had primary closure, I need to have a membrane there, or else that soft tissue will grow in. If I didn't have primary closure, like on the mesial site, I did not need to put a membrane there. But because I put a membrane on the distal, I just made it slightly bigger and cover the mesial also. And again, whatever's exposed to the mouth, we talked about at length last lecture, whatever's exposed in the mouth will dissolve very quickly. And everything that's under the tissue will stay there for 6 months. Good, that's my post-op X-ray. We did a sinus lift here also. I'm not going to talk about the sinus lift part because that was superfluous to today's lecture. Okay, so we got done in 36-minute overtime. Well done.
We have
okay.
all the questions.
All the questions. I heard you didn't stop me once, so I know either everyone's very bored by what I was talking about, or we had lots and lots of questions.
You could let you get through the material for those of the attendees.
Yes, anyone that has their families waiting for them. Usually I would say patients waiting for us, but today, unfortunately, that's not the case. Yeah, so anyone needs to go. Obviously, credits are good. The test only has to be taken if you're watching this on YouTube after the fact. If you're here live, we know that you were listening very attentively the whole time. Again, just to put in my email address one more time, submit questions and cases to work up together. And if let's offer this. The first doctor in this room who's going to be doing seeing a patient when this coronavirus passes and we can see patients safely again, the first person that wants to work up a case together, and we could do a live demo. We could put it up on the site where everyone can come in together and watch it together. Happy to do a workup together, display the case, and do a virtual chairside mentorship free of charge. So first one to jump on it, please do.
Quite an offer.
As assuming it's not me that gets back to work first. If I'm back to work, bets are off. But if you're back to work first, it's all good.
Can we publish that? Can we feed that, stream that live when you do that?
Yeah, I'd love to. Yeah, if we get the doctor's consent and patient's consent, we'd love to stream that live. Okay. No pressure. We won't. How about we won't say the doctor's name who's doing the case in case something goes terribly wrong. You don't want to end up a meme someday. Okay, so let's get to our questions here. Let me see if I can pull them up here.
You know what, before you jump in, let me just reiterate what I said at the beginning regarding the CE. It should come within 2 weeks to your email address. And again, if you attended live, as Robert Mikhli just said, then there's no need to complete the 10 question test, but it is being recorded and all of our past webinars are being recorded as well. So if you want to watch those, then go ahead and watch them, submit the quiz, and we will send you the CE for that. And we have a lot more webinars coming. So check it out on blueskyplan.com/webinars 2020. I just sent out the link, and also the Blue Sky Bio user group and the viral education group as well. Okay, go ahead.
Okay. Back to big. Let's get our Q&As. We got 31. Very, very few questions today. We usually have had over 100. Okay. I think I spoke too fast. Okay. Dr. Springs asked, does your warranty cover replacements of crowns, bridges, implants due to 3D maxillofacial growth over the patient's lifetime? I'm not following the question. Does your cover replacing the crowns or bridges implants due to 3D maxillofacial growth? I'm not sure what the 3D maxillofacial growth is. Please clarify that question. Because I'm only doing the implants and not the crowns, officially it doesn't cover the crowns itself, but in practice, nowadays I'm designing my own stuff in either Blue Sky Plan or in XOCAD, and I'm sending it out to a lab or to a buddy of mine who has a mill who charges me costs. So it costs me a few bucks to mill it myself. I'll just put the new crown in it myself and not bother the general dentist as a service. Officially, it doesn't cover that for me, but in practice, I end up doing the crown also, or sending the crown to the referring doctor to cement. But if you're or screw in. But if you're doing everything yourself, then I guess it would be included also. So just build that into your potential costs. And the way mathematically I had that the warranty work is, let's say I see 100 patients, and I'm seeing 100 patients once a year for a checkup, and I'm charging each of those patients $95, right? So that leaves me $9,500 in a little piggy bank for my complications, right? So I'm going to hopefully use way less than that in terms of what I'm going to need to spend both time and actual materials on treating these complications in that course of that year. So let's say for every 100, we're going to have, let's say the average is 2%. So let's say it's 2 patients that are going to have a complication of some kind. They're mostly not going to be catastrophic that I'm taking everything out and replacing it. It's going to be much less than that. That'll be 1 in every 2, 3, 400, 500. So I'm still way ahead in terms of that $95 charge as being in the piggy bank. And again, the people who have the problems are usually the ones that didn't come in, and then I have no problem and feel no pangs of guilt not charging them for whatever needs to be done, and they don't have a problem paying it because they realize, yeah, I didn't come in, it's kind of on me, so I can't come here and ask you to do it for free or expect you to do it for free because it was on me that things went south. Dr. Hassan asks, any difference in pure titanium and titanium alloy in success rates? So no one is using commercially pure titanium anymore. Everyone is using an alloy. The alloys are stronger. That's why. Sometimes they want to add some softness to it so that they can treat the surface a little bit better. So some of the alloys will be slightly more malleable, but it's basically type 3 surgical titanium is what just about every implant in the world is using. So in terms of success rates, no difference in what different companies are using. Good. Eitan asks, can non-conical implant be placed subcutaneously? So the answer is yes, but I could spend a long time talking about implant connection types. I'm a really, really big proponent on the conical connection. And the industry is also. Most companies want you to use their conical line of implants. Almost every company has it. They want you to use it because they know it's better. They know they'll have much less complications with it. But they also realize that you're going to need a new prosthetic kit because the transfer copings won't fit each other. They're not they're not cross compatible. So there'll be an added expense, which is why practically the internal hex is probably still the most widely used implant in the market. But there's a significant drop off. And I can show you some studies and some videos showing the difference between them on a microscopic level of micro movement of the parts within the implant under function, and you can see bacteria pumping in and out of a hex implant. When you have a conical connection implant, the whole implant shifts with the abutments, and there's no micro leakage. And with micro leakage is where you're going to get your bone loss. So the answer is, can you place them subcrustally? Yes. Do you run the risk of having more bone loss? Yes, you have the risk of it to a higher degree than conical, but still the advantages of placing it subcrestal still outweigh the potential risk of micro leakage. That's not the case with every implant system. The Nobel Trilobe implant, the Nobel Replace Select, is their most popular implant. They have a conical line of that same implant. The body's exactly the same, So surgically placement is exactly the same, but the prosthetics are totally different. And they will tell you, please buy the conical implant. It's way, way better, because the Nobel implant, which for a time was the most popular implant in the world, that Nobel trilobe implant had a standard 2 threads of bone loss around the implant, just about every implant placed. And no one was sure why until we started looking at that micro movement of the prosthesis against it, and you saw bacteria pumping in and out. So that implant I would not place subcrestal, because I'm guaranteeing I'm going to have bone loss to that second thread no matter where I place it. So if I place it subcrestal, I'm going to have that much more bone loss. So in that specific line of implants, I wouldn't use it, but practically in the internal hex implant, which is your Blue Sky has an internal hex. MIS, a very popular brand, is their standard one, is their internal hex. What are some other companies that are internal hex? I'd say it's probably, again, the most popular on the market. It doesn't leak that badly, but still significantly more than a conical connection. Okay, can't the technique of bisecting the tissue rather than free gingival graft? Can't get it. Okay. Again, small group, I'm happy to go through it in more depth. But again, just to briefly review, we talked about the only way soft tissue is going to heal, epithelium is going to heal, is from the borders. So if I have 1 millimeter of keratinized tissue and I bisect it, so now I have a 0.5 millimeter on each side, what's going to heal in between them? Only one thing can heal, whatever is the border of each side. So if it's keratinized tissue, it's going to be keratinized tissue filling in the whole gap. If the side of it's mucosa and the side of it's keratinized tissue, they're going to kind of meet in the middle. So you're not going to get regrowth. So that's why I'll go on the palate. It's easy because you have endless attached tissue on the palate. On the lingual, you're more left with whatever you have there. So if you have 2 millimeters to start, you can turn 2 into whatever you need to. 2 is easy. 2 or more is easy. 1 is hard because your incision's got to be dead on for that to work. And that not only is the case, sometimes it's difficult to get that to work, but that's the concept. Tissue can only heal from what is on its borders to fill in. So if it's attached tissue, that's all that will fill it. Hope that helps. You are moving so fast. You're right. I'm sorry. I really ran through this. I wanted to get through a lot of material in a short period of time. And again, we'll set up a small group. So again, there's my email address. Shoot me an email. We'll set it up for next week, probably at the same time, where I'm happy to go into do it in one long session or do it in a few shorter sessions and really go into it. When it's smaller groups, we can also have it interactive where people can speak in the middle. They can raise their hands and I can answer questions. When we have 200 to 300 people in a group, it becomes impossible. But smaller groups, it's absolutely possible. So, Dr. Ali, I apologize. Okay, Reza asks, what is the minimal or maximum inter-arch space needed for all-on-4 max, fixed, or removable? Good question. In full arches, it varies based on the material you're using, but an easy number to remember is, let's say, 15 millimeters from the platform or your implant to the occlusal table. That's the easy one. You can cheat on that if you're using different materials, but that's the easiest number to remember. And it's always better to have more space than less. Sometimes you can't have more space because you're really limited by their inter-occlusal space and the amount of bone you have. So there's only so much you can reduce to give yourself room. But 15 is your standard number, easiest to remember. Okay, Dr. Valensky says, thank you, you're welcome. Asks again, I saw a lecture about putting an implant through an impacted tooth. What you say about that? So I've seen case studies where they do that. So just again, think about our biology. So the question is asking if I have an impacted tooth and I want to, and most common is your impacted cuspid that's laying, vertically across the ridge, and I have no space. It's laying horizontally. I have no space vertically to place my implant because the tooth is sitting there. And to remove that tooth is a traumatic procedure. It's a lot of bone being removed to get that tooth out. It's a big tooth at this point. If they're a fully grown adult, and that's going to be a big pain in the neck to remove. I'd much rather remove it when they're young and before the root really forms. Or orthodontically pull it into its right place so we don't have to do an implant later anyway. I'd rather do all of those. My son actually had it impacted recently. Had both maxillary cuspids were impacted. He had retained his primary teeth for too long. It was my fault for not diagnosing it early enough. So I went to his orthodontist office, and the same day he was already there, I said, you know what, let me just lay a flap for him, and I'll let you put the bracket on today. It was already through the bone. It just needed some soft tissue exposure. So I laid a flap, put a bracket on it, and it pulled into place. That's much easier. But what you're asking is, once it's already fully grown, what do you do? So in case studies, they've shown drill right through the tooth and place your implant right through the tooth. So that could work. Or what could happen is you have, first of all, only mechanical stability into the tooth. You're not going to get an osseointegration from your tooth structure. It's not going to grow any material into the implant. So it's only a mechanical connection there. The only bony connection you're going to get is however much bone you have that's not, that's before you hit that cuspid. But you also have to be careful of, when you go through that cuspid, are you going to hit the nerve of the tooth? And then how are you going to do a sideways endo in that tooth? So I personally don't like that idea of causing a mess. I've seen case studies that it's done, but my guess is you're not seeing anyone publish when that goes really, really bad, because they'll say, yeah, it was a bad idea, I'm never doing that again. But the guy who publishes the case study, had it happen, worked well for him. So I would personally remove the tooth myself, and I've done that many times. But again, I've seen it done, but I don't think anyone's recommending that as a primary means of treatment. But good question. And again, just another example of understanding how the biology is working lets you make a clinical decision. Dr. Hassan asks, how do I gauge when to early place, immediate load, early load without an ostel? So it's kind of, you know, you're hedging bets on percentages and on your feel of how strong that bone is. But you're taking a big risk every time you do it, because the whole case could fail because you went in too early. And those osteoblasts were not finished doing their job. They're still too immature. The mesenchymal cells are still present and have not differentiated yet. And now you have fibroblasts forming instead. So it's a risk. And no easy way to say. I'm much faster to be able to restore things earlier with an ostel, because I have nothing to lose. I tell the patient, okay, you have a wedding coming up, come in 2 months out, 6 weeks out even, let me measure it. If I had, let's say, an 80 stability on day of placement, I just want to know it's going to be greater than 70 at 6 weeks. If it's greater than 70, I know it's not going to dip past that, and I can go ahead and restore it. So no problem. But that's if I'm really rushed. In general, I always tell patients, if you're not in a big rush, let it sit for longer. You're only better off waiting longer. But good question. The subcrestal implants can be harder to restore. How do you deal with that? So I hope we talked about that with the Uncovery kit, that profile kit. Makes it way easier. The whole idea is giving yourself room. So it's not hard to restore. It just requires more thought in what you're doing. So it's subcrestal. Just make sure at your Uncovery you give yourself enough room. And when you give yourself enough room, you have an overabundance of bone. And then when you're done with your case, your implant is in bone, your abutment's in bone, and your part of your crown is even subosseous. And then everything grabs onto that and adheres to that. You're going to have a beautiful restoration that you cannot tell the difference between that and a regular crown. That's your ideal situation. I always tell patients when I'm doing these uncoveries and I'm taking out this profile kit, tell them they're numb. So it's not going to hurt, but you're going to feel a lot of vibration here. And I say, the problem we have is you have too much bone here. And remember, we did all this grafting to get all this extra bone. You're an overachiever. You have too much. Great job. But now I've got to make room so that I mold the bone that's there into the shape of a tooth emerging out of it. That's how I explain it to my patients. Okay, Vlad asked, why do you take the blood pressure before surgery? Excellent question. I skipped through that fast, and I wanted to talk about it more. So let me do it now. So 2 reasons. One is my immediate concern. If the patient has a very high blood pressure and I'm going to inject local anesthesia with epinephrine, I'm going to cause that blood pressure to increase further. If they had a pre-op blood pressure of 220 over 150, we're not doing the procedure today. I would much rather know that before I inject them than once they go into cardiac arrest in my chair. So that's the first and foremost reason that I'm looking out to protect the patient this day. Second reason, which is equally important, is patients tend to go to dentists a whole lot more than they go to their physicians. Meaning in their lifetime, they will have much longer gaps seeing a physician than seeing their dentist. So if someone else can get their blood pressure and say, whoa, it's really high, you're hypertensive, you have no symptoms now, but if you wait 5 years to go to your internist to get checked out, you're going to have damage to your vessels from having that increased pressure over time. So if I can push a patient in the direction of their physician earlier and just create longevity in their life, it's just I believe that's our obligation as healthcare providers to do that. So I do it as a standard before every injection I ever give for those two reasons, which I think are equally important. And I encourage you all to do the same. Dr. Ali asked, do you do after the surgery dexamethasone? So dexamethasone is very similar steroid to prednisone, which is what I give in the States. So yeah, any low dose steroid will work well. So dexamethasone will work, prednisone will work. Yeah, so excellent question. Okay, what X-ray holder do you use when you take your intraoperal X-rays? This is generally a PA. I'm not taking a bite wing. This is a PA, but you want to make sure that it's set properly. You don't want any elongations. You want it really parallel to the implant. So the patient's numb. It makes it a lot easier for them to bite down on a digital sensor that can just push into the floor of the mouth or into the roof of the mouth. And I want to angle things so that I'm bisecting the implant really well to get an accurate film, because if I have elongated or shortened, it's going to give me an inaccurate film, which is not going to be helpful. Good. Dr. Mose asks, can I seat a 3-unit bridge on 2 implants by cementing one side and screwing the other? So yes, I've actually done that sometimes. It can work. Sometimes you'll have one side that the screw hole will be unesthetic, but the posterior can work. So what I'll do is I will have everything set to go in the posterior. I could use then more minimal amounts of cement on the anterior, seat everything together, and then screw in the posterior as the anterior is setting. So the answer is yes. Dr. Torres asks, PAPPER, P-A-P-P-E-R, with a question mark. I don't know what that means, so please just clarify, and I'll get to it. Dr. Mose asks again, why aren't surgical guides routinely used in some of these cases? So again, I'm showing these as a very, very early on. I have a whole separate lecture on surgical guides. I am doing almost all of my cases with surgical guides nowadays. So they're a great, great help. But I realize at the same time that it's not the standard of care yet. So I want people to understand that you don't need a surgical guide to place an implant, but I will show you in our next groups how surgical guides will make your life so, so much easier. In Dr. Glenn's lecture that he gave in the most recent one, if anyone was there for it, just did he go into the surgical aspects, or was it only the fabrication part? Just drop in the comments if you can. Recommendations for smokers before and after surgery. Yeah, I recommend they stop smoking. So it's the same thing. I tell them they are excluded from my warranty program. Anyone with a autoimmune issue, a diabetic, because I can't guarantee their control, and a smoker, they're not under the warranty because I can't guarantee their body's going to hold up. I tell them, my line to them is, every doctor you go to will tell you what smoking does bad for their line of medicine. So let me tell you what it does for us. So smoking decreases the blood supply to the mouth specifically. And as you see the soft tissue in smokers, oftentimes they can have a mouthful of plaque and no redness around the soft tissue. So we think, oh, everything's great. No, it's just so bad that they can't even produce a proper inflammatory response to the amount of bacteria that's there. The damage is being done, but it's just not getting red because the blood can't profuse enough into the area. So the same way, I'm going to see delayed healing, and I'm going to see a much higher failure rate. In the literature, it's about in the high 70s, low 80s versus in the high 90s. So I tell them, if you ever tried to quit smoking, if you haven't yet tried, this is the time. You're investing a lot of time and money into this, so it's a good idea to stop. If you don't, again, we'll do it because it's still got a high 70, low 80% success rate. It'll still work overwhelming majority of the time, but it's, again, much higher risk. So I tell them, do you want these implants done for free? You want a payment plan that they will be totally free? They're like, yeah, of course. So I say, what's a pack of cigarettes today? So I think in the States it's like $11, something like that. So I tell them, take that $11 a day that you're paying. Don't even need to put it in a bank, and certainly not the market today, but just put it in a piggy bank. And you'll be surprised how fast that really fills up with a lot of money, and you'll be able to pay for these implants, totally. And you'll, on the side effect, you'll also add many, many years to the end of your life. So it's another plus. So that's what I tell smokers. When using a guide, my patients have very little pain. Pain is an unusual feature of placing implants nowadays. I completely agree. Yes, that's actually very true. But I don't tell them that, because then if they needed to take Motrin for a day, oh my gosh, it's killing me. Doc, what did you do to me? So I learned, don't do that. It's gonna hurt. It's gonna hurt a lot for about 2 weeks. And we call them the next day, oh, I just took a Motrin today and I'm great. Perfect, everybody's happy. Under promise, over deliver. But yes, I would say 80% of my patients have little to no post-op pain. Are the tie-base abutments for their conical connections? Absolutely. Tie-base abutments are made for conical connections. The most common one I'm using is the Max line of Blue Sky Bio implants. It is the same connection as the Nobel Active implant, but what they've done is they've taken the narrow platform, the 3.5 platform, and put it on every different body of implant. So my 3.5 implant has the same platform as my 5.0 and even 7.0 implant. What that does is it first gives me a lot less prosthetic parts, because I only need one transfer coping, one abutment size, one of everything. It's good for the overwhelming majority of situations. The only time there's a downside to it is where I don't have enough room to place the implant very deep subcrestal and have a very wide restorative space. So let's say it's a molar, first mandibular molar, and it's, let's say, a 12 millimeter space, right? Like a big wide space. So I need that emergence profile to start at the neck as wide as it can, because I've got a lot of distance to cover. So then the 3.5 is a little bit too constrictive. I'd rather it be a 5, because then I already gain 1.5 millimeters out to start. So it's going to start that emergence even further out. So that's the only drawback I find in this line of implants, in extra wide spaces for molars, where I don't have enough room to drop it more subcrestal, which gives me then more room to build that out. So those are the situations. In those cases, I'll use either I'll use a Blue Sky tissue level implant, which, if you are not familiar with it, it's a totally different concept. The finish line of the crown is built into the implant, and it's supposed to come through the tissue, and that's why it's called a tissue level implant. And it has a 6.5 millimeter platform, so it's got a very wide platform to start. So that makes those wide situations much, much easier. Or I'll use, they also have a 4.3 millimeter neck, or I'll just use a wider platform implant to begin with. So, but I would say it's, again, good in 95% of situations. Vlad asks, if I forward ouch test is positive. Yeah, so if you caught that, I didn't even talk about it, but you saw it in the slide. Meaning I'm forward torquing to see if it's integrated. I'm torquing only to what I'm going to torque the abutment. So yeah, every implant system is a little bit different, and in between 20 to 30 to 35 newtons of forward torque to torque in your abutment. Less if you're working with, let's say, a 3.0 millimeter implant, then those are just finger tightened, but everything else needs some sort of torque to it. So if I forward torque, do you remove the healing cap? or put on the cover screw, or do you still leave the healing cap for the implant to heal? I'll usually leave the healing cap, just put it back on. If the healing cap was already on, I'll just leave it on, because I'm usually testing that, or I was testing, I haven't done that in years already. I was testing that at the Uncover visit, because why not? It's already numb. If it's really loose, I'll put the cover screw back on. But in most cases, if it got to like 25, then like just a nudge forward, I'll just tell them, I'll put the healing cap. It's more than stable for the healing cap, but I'll tell the restorative doctor, give it a month before you restore this. Nathan asked, do the internal hex BSB Zimmer have a conical seal? No. There are two lines that have conical seal, are their conus and their max. The internal hex implant is a hex, no conical seal. Trying to decide between Blue Sky Bio Max guided kit versus internal hex kit. We place internal hex now. Wondering if adding max would be better to have different implant options, or stick with the internal hex since we already have all those components. Please advise differences between Biomax and internal hex. Yeah, so I think I talked about it a lot already. I would say the minds behind Blue Sky Bio would much rather have people buying the Max. They believe it's a better implant. That's why they came out with it later. They don't go back and take away their older lines because they're still very popular. And if they took it away, people would just go to a different company that sells a hex implant. But they will tell you, if you call their customer support, they will tell you the Max implant is a superior implant. And again, every situation I speak of other than that wide molar situation. So if you're going to be stocking and getting a guided kit, the truth is a guided kit works for really either one. It's just the driver they're going to give you is going to be a little bit different. The drills may be slightly different, but you could still do a guide with either one. But you have a lot less parts with the Max anyway. So even though you already have some parts now, those will get worn out over time. You'll be replacing them. Just the great thing about Blue Sky is their stuff is not going to kill you. Their materials, their implants, and their prosthetic parts are not expensive. So to switch over, getting a couple of drivers, you could keep your existing kits for drills. Again, majority of the drills is exactly the same. Maybe your final drill you'll want to switch out, but everything else can remain the same. Your drivers will switch, and that's really it. So I would, push you in the direction of the Max. That's what I did in my practice. I went through a stage where I placed a lot of hex implants. I placed a lot of their trilobe implants. I placed a lot of their hex implants. I placed a lot of their conus implants, and now I placed a lot of their Max implants. I really like the conus and the Max. Those are my two favorites. I don't miss the hex implants. I sometimes miss the conus in certain situations. I have a lot more Max implants stocked than I have conus. I have some, but if I need any size, I have that in stock in the Max, because they're also significantly less expensive. If you buy a pack of 5, they're $95 a piece. So you can't really beat that. So I just keep a lot of implants around, so I always have what I need. But good question. Can you please explain the mental loop? So it's a very in-depth question. What he's talking about is generally the inferior alveolar nerve exits the mental foramen, but sometimes gives a loop anterior to it and loops back, and you don't want to hit that either. So we'll go through it in detail in some CT scans. We could do it as a standalone CT lecture or in small groups. I'm happy to go through it also. But you want to see it on a CT scan and not drill into it. That's the short answer. And for overdentures. I don't know what the first part of that question was. So I don't know how to answer that. Dr. Martin, please replay that question for me. Vilma says, me with 2 E's. Again, I don't know what you're referring to, so ask again. Yvonne says, excellent presentation with 3 exclamation points. Thank you. Vilma says, now 3 E's with a me, and I must have said something at that time, and you were responding me. I forgot what my question was. Has anyone had this happen? I don't remember what I said. I remember saying something along those lines. Has anyone had this happen? You remember, Michael?
Offered to coach.
Oh, yeah. So the answer is yes. If you have it, first one that, again, don't bring a patient in before it's safe. Stress that. But get yourself treatment plan now. If you have the stuff now, let's work it up now together. We'll do that in a small group with everybody together, so everyone can learn from it, and then we'll coach you. No problem. Be my pleasure. JG asks, do you work with Canadian dentists? Yes, I love Canada. Why not? George Wing asks, do you correct the angulation on that molar implant with a Lederman burr? Fantastic question. The answer is yes. You can correct it with the Lederman burr, and that's what I'll do in situations when I need to correct angulations. In that case, again, it was still in a restoral spot, so I left it alone, and I keep that old case there because I want to show you what can and will go wrong. I hope over the course of working, I have less and less pictures to show of bad cases, so I try and hang on to some of the early ones, because you learn a lot more from a case that didn't go right than you do from a case that everything went exactly right. Dr. Jacobs asks, if you place an implant and you have a slight paresthesia, no other complications, radiographically well, what do you do? So you have to look at a case-by-case basis. If your implant is close to that nerve, just take it out. You could always put an implant back. You can't always put a nerve back. So if I had to choose between one or the other, I would just take it out, let everything heal, get the sensation back, and worry about replacing the implant with a shorter implant next time later. But paresthesias are no joke. Any soft tissue grafting webinar soon? Happy to do one. We don't have one scheduled. Blue Sky is now doing multiple webinars a day because so many doctors want to donate their time to help out colleagues during this time. So I think the queue is now going into like mid-April, which we're all like really holding our breath, so we're not working by mid-April. But at this point, I think mid-April is definitely on the horizon. So if we don't have it yet, we'll be happy to do it. Shoot me an email and we'll get it set up. Dr. Marr says, thank you very much. Learn something new each time. You're most welcome. That's why we do this. Dr. Ali says, when do I have to go for a subcrestal implant? So it all depends on your prosthetic workup. In a small group, I'm happy to go through a case very slowly, work up where is the crown going to go first, how much room do I need from that implant to be placed to get a proper emergence profile, and that will decide where my implant will go. I sometimes, in a otherwise normal looking case in terms of bone, place the implant 3 or 4 millimeters subcrestal because I know I'm going to need room to create an emergence because they're short teeth, right? Sometimes your crowns are very short. And if I try and place the implant at the crestal level, the tooth can get away with it because it's got 2 roots or 3 roots, and it's emerging properly out of those roots. But I've got an implant, so I've got to get that to emerge this way, not just up 2 parallel roots. So I've got to treatment plan things differently. So I'll place it deeper based on the prosthetic concerns. It's all crown down planning. Thomas asks, what is your experience of using post-op prednisone versus only conventional anti-inflammatories and analgesics, as patients are much more comfortable? Are patients much more comfortable? Any complications? So yeah, the complication that's most common is their heart will race, even though it's only 10 milligrams of prednisone twice a day. It's a very small dose. It's only for 3 days, so they're not weaning themselves off of this later. And I tell them if you have any complication with it, any side effects, discontinue immediately. It's not going to help your overall success rates, but it just will keep them comfortable longer. So it's definitely better than just using an NSAID, in my experience. But if they can't take it for whatever reason, no need. Long term, no difference. Just short term, keeping them comfortable. What is your experience with osseoidentification? Good question. That's the DDS burrs. So I've used the method before those DDS burrs were even there. I myself was running burrs in reverse in thinner ridges to try and push out the bone, and in softer bones certainly to push out the bone rather than to cut it away, because the burrs are designed to cut. If the bone is soft, I don't want to cut it away. I want to push it away. And you can run the burr in reverse and with a lot of irrigation push into the area, and it'll push the bone out. I know their flutes are made differently to be able to push the bone that's cut against the walls as well. So there's an advantage to that. What I've seen though is in novice hands, and I've seen many of these cases posted online, is that people that have very limited surgical experience are using those drills and using them incorrectly and having massive failures. We're using it where it's not indicated in hard bone, and you already have very poor blood supply because the bone is so dense, and now you're densifying it even more and you get no blood supply at all, and now you have a massive necrotic mess because there's no blood supply there. So I would say it's a nice tool to use in the right situations, but again, implants were done for a lot of years before it. It's not a necessity. It's a nice extra tool to have once you've gotten good at implants. So I'll say that. Prednisone dosage, 4 millimeter dose pack. So what I do is 10 milligrams twice a day for 3 days. So we're getting 6 pills. That's my dosage. The dose packs I know will also work. It's just, I don't know off the tip of my tongue what the dosage is because it's not my standard post-op med. If anyone else wants to post what they do with it, we could pass that along to Dr. McGillicuddy. Okay, George Ibrahim asks, can you explain which radiographs you take and how often you take them? And for implant patients, also same policy for perio maintenance. So are you asking during surgery or afterwards? So during surgery, early on, I was taking, everyone got a pin placed with the first drill, would go down about 6 millimeters, place a pin, take an x-ray, make sure my angulations are good, and continue. If it wasn't right, I would get it right and take a new angulation. Nowadays, with guided surgery, I do that much, much, much less because my first drill goes in, I visualize that it's accurate, I know my roots are nowhere near where they're gonna be, and I don't need to take that many films. The only times I'll still take them is like if I have a very tight space between 2 roots, let's say a lateral incisor, very common, especially a congenitally missing lateral where the orthodontist did not upright the roots as much as I would have liked to, and I have like very little margin of error there. Even though I'm using a guide, I just don't want to drill into a root and find out afterwards. So I'll take step x-rays then. That's during surgery. If you're asking me after surgery, I'm taking at least yearly. I want to see the bone levels yearly. And I want a level x-ray with the bone. So I want something that's going to be horizontal to the level of the implant platform. So that can be, it might be a bite wing, it might be a PA, depends on the situation. And perio maintenance, yeah, I guess if you have a defect, same idea. You want to check on it annually and make sure that it's maintaining where it should be. And nowadays with digital x-rays being more or less a standard, very few offices are using, in my experience, are using film still. So the level of radiation is so much less. There's not really a thought of I'm going to radiate my patient by taking 1 extra PA once a year. Okay, Nathan asks, why do you charge for temp restoration? What do you charge for temp restorations versus placing healing abutments at uncovery? How long in temp before final scan? Good question. So what I'll do is, again, I'm scanning them at the day of surgery. For me, I am 3D printing their temp, so it doesn't cost me much of anything. It's time more than anything else that I just, right after surgery, I try and get it done the day of surgery because I hate looking at my schedule the next day and be like, oh no, I have to 3D print like eight temps today. So I try and do it the day of surgery while it's still fresh in my head, print it, and then put it in a little box and store it for later. The difference is I'm using now a tie base versus a healing abutment. So there's about a $30 difference between the two, but I'm saving myself a lot of chair time doing it this way. So for me, that was a wash. I'm also now saving on, I would send my referring doctors transfer copings, but now I have a digital file of the final restoration because I just put a temp in, which is the final restoration. If everything looked good, I tell them, if it looks good, let me know. I'll email it to the lab and they will send you the final restoration milled for very inexpensive. So I'm saving money on parts doing it this way overall because I'm not sending transfer coping and I'm not sending analogs. They're saving time because they are now seeing their patient where it used to be I'd see the patient They would take an impression, they'd send it to a lab, they would have fees involved in that, they would then have a crown made and done. Now we're working modelless. They get the crown shipped directly to them. In the first visit, they're already delivering their crown. So for them, it's golden. They love it. So everyone's much happier, and I'm saving more money that way. So for me, it just makes a lot more sense. So my biggest cost is obviously the intraoral scanner, but I'm charging, I kind of worked it into my practice. I don't charge them to take an intraoral scan. That's included in their consult visit. I am only charging them for a surgical guide, which I charge $350 for. So that more than paid for my printers, my intraoral scanner even, which was much more expensive than the printers, but that's what pays for itself. And also just ease of practice, and you doing cutting edge dentistry is what I want to do. Just made life so much better and easier. So that's the long answer. How long in temp before a final scan? And again, we're not oftentimes not even taking a final scan because the temp was great. I'm just making a copy of that in zirconia. So, you know, no need. But if I'm placing a healing abutment, I generally want the tissue to heal for about 2 weeks. So that thing, that's the question you're asking me, is how long from uncovery to the impression? That's a 2-week process. Good. Mohammed asked, you mentioned prednisone. Is it effective in giving that after surgery? My answer is yes. I thought we get maximum effect if the patient start taking a day before surgery. No, so the studies show it's 30 minutes prior to surgery to take an anti-inflammatory, and that's usually an NSAID. That was the study that was done. I'm not aware of a study that was done with a steroid as well, but the two work well together. So if they did indeed bring their medication before, I'll have them take everything 30 minutes before. So they're going to take their 600 milligrams of ibuprofen. They're going to take their prednisone. They're going to take their antibiotic. All three before surgery. If they brought it. If they didn't, it will still work fine afterwards. And I have just in the office, I keep plenty of ibuprofen over the counter. Okay, good. And is it a standard for every implant surgery if patient is healthy? So yeah, for my protocol, it's standard. Night guards, always, never. Question mark, Dr. McGillicuddy. Yes, night guards very important if they have TMJ issues. So we talked about that in their pre-op, and afterwards, that's going to be important. They're very helpful. But again, it's usually the referring doctors are getting involved in the night guards. I'm not, but I advise them to do it. Nowadays, with zirconia restorations and full counter zirconia, certainly in the posterior, they don't chip like they used to. So it's a much less of an issue. But if they're bruxers, you definitely don't want that going on the implant body. All that force will get transferred now. Instead of chipping the crown, it'll just get transferred to the implant, and you could get broken screws. I have had that happen. So night guards are very helpful for that. If they are nighttime bruxers, clenchers, then yeah, that's also in the contract. They're going to follow their dentist recommendations, and it actually says, I'm pretty sure, should we go back and check? I'm pretty sure it says including use of their night guard. Good. So definitely not never, much closer to always. For implants that are subcrestally placed, how is the bone loss after placement? So almost none, really. It's bone grows over the top of the implants almost every time. Where I do the uncover and I say, I know I put implants in here, and I took an x-ray, so I know they're there. I just would never be able to tell until I go digging for it. And I know exactly where it is, so I can do it that way. If you hang onto your surgical guide, it makes it much easier, especially if you're doing multiple implants, because then you could just do a very shallow drill onto each of those spots and then just widen and deepen from there. Good. And that's really the beauty and the big difference when you start using conical connections, subcrestally placed versus a flat connection. Big difference you'll see in the amount of bone that's retained. Dr. Wang asks, after the lance, do you recommend 50 RPMs and 50 Newtons with the twist drill? So I personally like to turn it up all the way. I want the drill to work efficiently. I'm going to guide it where it needs to go, or my guide is going to guide it where it needs to go, but I want it to work very fast and very efficient. So I turn it up to 2,000 RPMs. 50 RPMs to me, I don't think you're going to cut well. I'm going to turn up to 2,000 RPMs with 30% water on it and full torque. I want this thing cutting. I'm going to make sure my hand is going to push it in the right direction, but I want that thing cutting as efficiently as possible. When I'm placing the implant, then it's going to more like 50 RPMs, and I'll have it go in at about 30 newtons first. Then when it torques out at 30, I'll either hand torque it the rest of the way down or increase it on the handpiece up to, my handpiece can do up to 80 newtons. And I can do it, I'll do it that way. But I also want to make sure that if I don't start with 80, because if I start with 80 and it only gets halfway down, now I may have a problem because I can't back it out because it's too tightly wound up in there. Or let's say I get 80% of the way down and I can't back it out anymore to open up my osteotomy. So I don't want to put too much torque initially. I'll first do 30 and see where it stops. If it stops halfway down, I'm going to take it out, make my osteotomy a little bit wider, and then place my implant that way. And we go through that on the hands-on section of like the very, nuts and bolts of exactly what all your settings are and such. To go through it now is just giving you numbers. When you do it during a surgery, you understand what's going on and you can feel what's going on. Dr. Bolding asked, thanks for holding the question and answer until the end of the lecture. Very good info. I was hoping to get into greater depth the last 45 minutes in the webinar, pre-surgical, surgical, post-surgical details of the case examples. I would love another webinar where he goes into greater detail of this information. Thanks for putting it together. It'd be my pleasure. Again, I just didn't want to hold everyone for, now we're at 2.5 hours in. I didn't want to hold everybody here. We still have 125 of you hanging on into the afternoon. So I just didn't want to go to ad nauseum. I would have been here for 3+ hours otherwise. So, and then before the questions. So I went through it quickly, but again, shoot me an email. We'll do it on a day next week that makes sense for everybody. I'll go through a few cases, really slowly, step by step, and you can jump in with questions as we go. Okay. Aviat says exactly like 13 or 23. I assume you're talking about tooth numbers. 13 would be, what is that? The maxillary right quadrant. Sorry, I'm still thinking in American tooth numbers. That's your cuspid. Yes, 23 would be your maxillary cuspids. I assume that's what I was talking about, the cuspid spaces. What is the narrowest implant diameter for posteriors and upper centrals? Okay, good question. I would not use anything less than a 4.3. Let's say that for the posterior, because anything thinner than that, I feel has a good chance of breaking. And again, the implant body just doesn't have enough titanium and it doesn't have enough meat around it to be able to hold on to those forces. And the last thing you want is 5 years down the line to have a sheared off implant that just couldn't withstand the force. I'd much rather build out the bone and put a proper size implant than trying to squeeze in a skinny one. For the upper centrals, 3.5 is also kind of thin. I'd rather not, but I would do it if that's what is needed in that space. But usually you can fit a 4.3 into a maxillary central space pretty easily. So less of a concern there. Okay, got some thank yous. Sorry if you went over, but if you went over this, but how do you check stability of the implant? Yeah, I think we went over it a couple of times. Hopefully you caught that. But the two ways, the Ostel and the forward torque. Okay. Should you have the patient take dexamethasone hours or morning before? We talked about that. 30 minutes before. Prednisone dosage, we talked about that. 10 milligrams twice a day for 3 days. Can I join an implant to a natural tooth? I've seen it done in Europe. Good question. I've seen it done also, but the literature frowns upon it. So what that means is the elasticity of a tooth in a ligament is very different than an implant in bone. Implant in bone should have zero mobility. A tooth should have mobility. Again, not a lot of mobility, but it should have some bounce to it. So if you're going to have a very firm structure in one, splint it to a non-firm structure in the other, and you have some movement there, something's going to give. So either the ligament tooth can get ankylosed, which is in and of itself is not the end of the world, but not ideal, or the cement will debond because that's trying to move, and you'll end up getting secondary caries there. Or you could have it bouncing too much on the tooth and then causing a fracture on a screw on the implant. So it's just unpredictable. I've seen it done also. And if it's in someone's mouth, I'll tell them, we don't normally do this before the point, but after the fact, it's already been in your mouth for 10 years. I'm not going to tell you to move it, but I will tell you it's at a higher risk than anything else, that if it wasn't splinted. So I've seen it done, but again, seeing it done and seeing it work in a couple of people is not a reason to do something. It just means it was predictable. It was not predictable, but after the fact, you could look back and say that it worked, but that doesn't mean that it was predictable in the beginning. And will it work for the next person? In general, cost of graft procedure versus with bone and membrane, worst case scenario. So in my office, I charge $400 for an extraction. And again, I do that for an easy extraction versus a hard extraction. I don't like to differentiate because you have a general idea of how difficult an extraction is going to be, but I'm sectioning most teeth anyway, and I'm taking them out as they should go out. So for me, I'm giving a flat fee for the extraction. The bone graft, I generally charge $400 for a socket preservation. And if I'm using a membrane, it's going to be an extra $325. That's my standard fees. But again, every country is going to be different. Every area is going to be a little bit different. I'm on the mid end in New York. I know in Manhattan, which is not too far from my office, fees are going to be much higher because rent is much higher there as well. So everything is much more expensive, and fees are more expensive, and people kind of understand that they're going to be paying more. Okay, and when do you redo implants for free if failures happen? So I talked about that. If they've been coming in for their yearly exams and something unforeseeable happened and they're not smoking and they're not a diabetic, it's nothing that was their fault. Just sometimes stuff happens. So those are the times when it's paid for. If they don't show up for their post-ops, then yeah, I charge them for any replacements. For beginners, should I place some implants freehand before doing guided surgery? Great question. The answer is now I've shifted my my outlook on this. I used to say it's impractical to say that GPs are going to be placing every implant with a guide, so better learn to do a freehand and then use guides, sparingly, or increase their use over time. That makes your life easier. I've changed my outlook on that. Now guides are readily accessible, so you should still know how to do implant freehand, because there are times when you fabricate a guide and something doesn't fit right, and you make your first osteotomy and you say that's not right, and then you change it. So you need to know how to place a freehand in those situations. You don't want to tell the patient, sorry, go home, I got to make a new guide, I'll see you next week. You want to be able to finish the case where it's reasonable. So you should know how to do both. But for the first ones, it takes a lot of the stress and pressure off of implantology to do it with a guide. So I would say your first cases you should do with a guide. Once you get comfortable with that, do a couple of straightforward freehand ones just to get used to when guides don't fit exactly right. But again, nowadays guides fit to a much higher degree than they used to. So that chances of needing to freehand it are less and less. But again, it's just another skill to have. But I would say nowadays I advise starting with guides. And if we're doing them together, that's exactly what we'll do. Can you please explain about implant position in case surgical guide is hard to fabricate, especially in patients with tremors? Implant position in case surgical guide is hard to fabricate. Patient with tremors, why would that make it more difficult to fabricate a guide? A guide makes your life much easier there. If the patient's moving, if you have a guide, it's making sure everything is locked into place and not going anywhere else. I'm just unclear of the question. If you want to clarify, please do so. Vlad asks, what do you think about short implants? Love short implants. What do you think about putting a 3.7 millimeter wide implant in the molar site? Talked about that, hate it. Love short implants. Short and wide implants are great. Again, because we talked about the bone to implant contact, just recognize when the implant is thin and long, it has the same bone to implant contact as something that's wide and short. It's a matter of how much bone is touching metal. That's what's going to decide your stability. So short implants work really, really well. And because our surfaces are done so well nowadays, we can get away with a lot more stuff than we used to. We talk about a implant to crown ratio. For a tooth, it's got to be 2-to-1 of root structure to crown. Implants, it's for sure the opposite. Like you could get away with a 2-to-1, 2 parts crown, 1 part implant every day on a short and wide implant. So it's not so much the length, it's the surface area. So as what you give them in length, you make up with in width. So that's the answer. Do you split your implants for overdentures? Do you split your implants for overdenture maxillary cases? Excellent question. So whenever possible, yes. I love to put something to split them because I'm increasing their stability for sure. What I like to do is have a bar made with locators on the bar. So the locators are rock solid and parallel and everything's going to fit and snap in really, really well. And the bar screws right into those implants, so everything is nice and snug and secure. So when done well, they work really well, but you have to have enough space to have that work. Sometimes there's not enough space for a bar. So I will still have implants done with locators freely. I've placed them parallel, I hope, with a guide, so I know that they're in the right spots. And I make sure that overdentures, sometimes people forget, it's just retaining the denture, but it's not supporting the denture. So a bridge supports and retains, which means everything's sitting on the implants, nothing is sitting on the gums. In a overdenture, it's not the case. Everything is sitting on the gums, it just doesn't get dislodged because the locators are holding them in. So if it's done properly, it will work even without a bar. But what ends up happening is that you get some resorption. People don't come back for checkups. It's now putting a lot more force on the implants, not just retaining them, it's also supporting them, that you start to see failures. So you avoid headaches down the line when they're splinted, but it's not always an option. The way around it is to just see the patients every 6 months to make sure that you're doing a proper reline and making sure everything is sitting in there properly. How do you break the news to the patient if you have a failed implant? Yeah, you just, it happens. And I tell them that in the beginning. Hopefully you came to me because you think I'm a good doctor. I'm in this profession because I love what I do, and I hope I'm a good doctor also. We're in this together. I'm going to do my best. You're going to do your best, and these are the odds of that working. But I tell them I do many thousands of these a year. That means that we do have failures. It's part of the business. So I don't take it as personal if something fails. I will investigate, could I have done anything better? Absolutely. But I also recognize that even that, if I I could have done something better, I'm human. I will make mistakes every now and then. I just want to make the same mistakes over and over and over again. I want to get better and make better mistakes as time goes on. But more often than not, it's just failed. Like, I don't have a good reason to tell you. I like to have a reason and say it happened because of this, but sometimes just didn't work out for whatever reason. But that doesn't mean the next one won't. Rarely, almost always when I've had a failure where it's not linked to a medical condition that we didn't recognize was there, the second one will work. I've had in my career, I think 2, maybe 3 times that I've done a third round, and those have all worked. So eventually they work. But obviously the overwhelming majority, high 90 percentages are working the first time. Good. Biomax, so Dr. Samaro says, Biomax it is. Glad I brought you on board. Super excited to start guided. Why is that last delivery fully guided placement by hand and not with a handpiece? Just curious. trying to understand what that. Why is that last delivery fully guided placement by hand and not with a handpiece? In the guided kit. Good question. Why have they not developed that you could place that implant through the handpiece? There was a fear of more complications if you place it. I have had this conversation with the designers at Blue Sky. Why they don't have they plan to have a handpiece attachment to go with their guided kit. They didn't because if the angulation of the handpiece was a little bit off and it's so locked in, you had a fairly high rate of fracturing the driver head in the implant, and it just became a headache to get it out. So they figured just to make everyone's lives easier, they just left it out of the kits. So what I actually do is I kind of hack around it. They have a thumb driver. I have an attachment that can attach that to my handpiece. So it's the thumb driver part. I have that attachment that will attach to the handpiece, and I drive it through that way. So I kind of cheat my way around that because I also like to place it with a handpiece myself. That being said, I oftentimes will use the guide just for the first drill, and I can oftentimes I'll freehand it after that. It just depends on the given situation. It's just a comfort level for me. Once my first drill's in there, it's just following that same straight line. If it's a single implant with 2 teeth right next to it, I hope I'm doing that well every time. And I'll just do the first drill with the guide and then freehand after that very quickly, and I'm done. But when I'm using the guide the whole way, which is multiple implant cases all the time and others, and I want to paste it through the guide, that's what I'll do. I'll place it into the osteotomy with a thumb wheel, take out the thumb wheel, put the attachment on, put my handpiece on, and then drive it the rest of the way down. So that's your hack around it. Okay, Vilma says, hope it's soon. I'll prepare. Excellent presentation. Thank you, and looking forward. Okay, Dr. Gunn asks, is it important to use original restorative parts from implant brand compared to using milled abutments done from labs such as Atlantis or Argon? So every machine part has a certain tolerance, which that means is plus minus this amount is where the machine part will end up. Those tolerances are tighter when the manufacturer is manufacturing their own parts. But when you're retro engineering a part to fit for somebody else's thing, that's when you start to have some discrepancies. So I'll tell you, there's machines and there are machines. Some machines have tighter tolerances, some have very sloppy tolerances. The sloppy tolerances are where parts won't fit exactly right. But the better companies, the better machine parts are working well. So whenever possible, it's always best to use the same brand for everything, because you're going to make sure that the same company that is machining their implants is going to machine those abutments on those same machines, and the tolerances will be within each other. So it'll work. Once you're retrofitting, again, there's just more play involved. And sometimes you'll have some parts that will fit, and sometimes you'll have some parts that you feel when you place it in, just doesn't exactly fit right. It'll go, but it doesn't exactly fit right. So you have to look at what are you saving on any given situation. Nowadays, I think that the easiest way to save on implantology is to use companies that are reputable companies that have been in this game for a long time. They're not going anywhere, that you're going to place your implant in a year or two from now, they're folded and there's no way to get their parts. Stick with a company that you can afford their implants and afford their parts. If you want to do a Straumann implant, they're really expensive implants, then also splurge for the parts. It's like if you buy the Mercedes, you're going to have to put the expensive gas in it, right? If you want to drive a Ford, you can afford the cheaper gases. So I would say it's just easier to stick with one company all the way through. It just makes less headaches that way. And again, that's why I personally prefer using Blue Sky, because their implants are affordable and their restorative parts are affordable. You don't have these astronomical fees. So when I have sometimes a part that I'll need that I didn't consider in advance, that's going to cost me $30 or $40. That's a total wash. If there was a Straumann part and that part is $250 and I only had 4 implants, oh, that's already different. Like, that's money. So it's just a lot less headaches. That's why Blue Sky is just an easy company to work with for that reason. Is it possible to get to the PowerPoint presentation to be able to go through the material and move through quickly? Yes. Well, I won't, not to give you the presentation because I have a lot of the patient information in these things. I'm not going to give it to you, but we said we'll do it in a small group. So shoot me an email and we'll email you that group time next week. Eitan Liederman Burr, yes, the Liederman Burr is excellent. And if you want that small group, we'll talk about it in greater depth and some tricks of how to use it well. Kevin Mose says, thank you. These lectures are unprecedented. Oh, wow, thank you. They are precedented. I've given them myself. But yes, they're very helpful. And your lecture is free. This is excellent. Let the knowledge flow, as I agree. Are you familiar with the magnetic mallet machine? I am not. Would you repeat the prednisone dosage? Yes, 10 milligrams twice a day, 6 pills total over 3 days. Using PRF to fill in the gap, the flap, when you shift vestibule, it'd be better. Yeah, so what you're asking about is your last look at my email address. If you don't have it, let's skip down to those large flap cases. And that's what you're asking about. And your statement is correct. Yes, a PRF there is better. Just because it covers the wound, less chance of dislodging of, where's that picture? Less chance of dislodging the clot. So yes, better. Where was that? Okay, I'll find it in a minute. But basically you're asking about when I have those large flaps and I'm really displacing the tissue. This is not the picture I'm talking about, but when I have, let's say, if I left this open, would it be better to put some PRF there? Yes, absolutely. It'll heal faster and less chance of the clot being displaced. Nathan asked, do you ever use a piezo for extractions? I think we talked about that in the previous lecture. I have, but I don't do it regularly because I don't find it to give me much of an advantage. But I know some people do and love it and wouldn't extract a tooth without it. What intraoral care do I use? I have the CareStream 3600. I am mostly happy with it. I was not happy with when a wire went out recently, which means just as I would bend it in this direction, it would go offline. If it was in this direction, it was online. And I was about a month out of warranty. And they said, okay, great, we'll send you a new one. That'll be another $30,000. I said, excuse me? How don't you just fix that wire? And they said, oh, we don't fix them. We just replace them. I wasn't so happy about that. So they sold me a extended warranty for a few $1,000s. But otherwise, it's a really good scanner and it works well. But everyone's got their own reasons for why they get scanners. We have a separate scanner lecture. We can get into all that later. Do you use triple Tay impressions? When I'm doing PVS impressions, I do use triple Tay impressions regularly. Yes. Thank you so much, Dr. Mikhli, and you are welcome. All right. Thank you to the 106 that stuck around all the way to the end. Okay. So again, shoot me an email. We'll get a small group for together next week for some more in-depth stuff.
Let me just comment on the intraoral scanner. The Blue Sky Bio is now carrying Shining 3D intraoral scanner for $13,999, and with that, you get, there's a list of different options on the site. You get a free product, including a mobile X-ray generator or some implants or some other items. So you can check out the Blue Sky Bio website for that.
Yes, and I think Michael said that because I did 3 lectures today, he's going to send me one for free. So thanks, Michael. I really appreciate that.
Thank you, and thank you for all your time and your presentations and your webinars. And we're going to keep the webinars running, so we do hope that everybody gets back to work quickly. But until that happens, stay tuned. Follow the schedule. We're going to keep updating it, adding in more webinars as time allows. And just again, regarding the CE, we'll send that via email within 2 weeks' time or so. So I'd like to thank everybody for attending. And Robert, again, thank you so much for all the knowledge that you give over.
Thank you. It's been a pleasure.